A very good morning and warm welcome to all the dignitaries present here. I am Momita from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clinic serves as a digital partner for this event, hosted by the Indian Association of Clinical Cardiologists. And the focus of today's session is Zonal Conference of Indian Association of Clinical Cardiologists. So now, without any much delay, let's begin today's session, for which I would like to invite Dr. Vignesh Jagnany sir to take over.
Should I begin, Momita ji?
Yes, sir.
Should I begin?
Yes, sir. Please go on.
Oh, thank you so much. At the outset, I welcome all the delegates who are here for this online webcon, CARDIOZONE 2024, hosted by Jharkhand IACC, Jharkhand chapter of Indian Association of Clinical Cardiologists, today on Independence Day like previous years. To begin with prayers, praying Lord Ganesh and Ma Saraswati, Vakratunda Mahakaya Surya Koti Samaprabha, Nirvignam Kurume Deva Sarvkaryeshu Sarvada. Ya Kunnendu Tusharahar Dhavala, Ya Shubhra Vastravrita, Ya Veena Vardanda Mandit Kara, Ya Shvet Padmasana. या ब्रह्माच्युत शंकर प्रभृति देवै सदा वंदिता सा मां पातु सरस्वती भगवती निशेष जाड्यापहा. Today is Independence Day, remembering Bankim Chand Chatterjee for Vande Mataram Sujalam Sufalam Malajaya Sheetalam Shashya Syamalam Mataram Shubhra Jyotsna Pulakit Yaminim Pulla Kusumita Drumadal Shobhinim Suhasinim Sumadhur Bhashinim Sukhadam Vardam Mataram Vande Mataram. Coming to our conference, CARDIOZONE 2024. So this is the brochure for this conference. The first topic is on the P wave, for which the chairperson, Dr. Syed Akbar Ali, Dr. Alka Gwalre, Dr. Shalini Tomar, and Dr. S. Kumar, clinical cardiologist from Ranchi. We begin this session. The P wave. Well, we all are doing ECGs, reading ECGs. Today, our focus is on the first wave on the ECG, P wave, which talks about the atrial depolarization. Before we begin the topic, let's differentiate between cardiac muscle and the skeletal muscle. We all know by structure, the cardiac muscle is short, thick, branched, and interconnected in comparison to long, cylindrical, multinucleated skeletal muscle. Cardiac muscle is stimulated either it is nerve stimulus or self-excitable, whereas skeletal muscle is only stimulated by the nerves. The contraction of cardiac muscle is as a unit, whereas skeletal muscle is individually activated. Cardiac muscle has long refractory period of almost 100 times the skeletal muscle, that is 200 millisecond in comparison to 1 to 2 millisecond for a skeletal muscle. The P wave originates at the AV node as we see in this picture. It is the first positive deflection on ECG, which represents atrial depolarization. Normal duration of P waves is less than 120 millisecond, which is represented by 3 small squares on the ECG. The axis of normal P wave is anywhere between 0 to 75 degrees, and it is upright in lead 1 and 2 and inverted in AVR. This is normal physiology. If there is a right axis deviation as seen in dextrocardia, There is positive QRS complexes, that is upright P and T waves in AVR. So this is different. This is just opposite of a normal ECG. In dextrocardia, the P waves are upright, whereas in normal levocardiac ECG, P waves are inverted in AVR. In lead 1, there is inversion of all complexes, that is, there's global negativity in terms of inverted P waves, negative QRS, and inverted T waves. There is absent R wave progression in chest leads with dominant S waves throughout. So we are seeing the just opposite effect if there is a dextrocardia. A normal sinus originated P wave has a smooth contour with monophasic in lead 2 and biphasic in lead B1 with a duration of less than 120 milliseconds, and amplitude is around about 2.5 millimeter in limb leads and less than 1.5 millimeter in precordial leads. If there is atrial abnormalities, they are more easily visible in inferior leads, that is 2-3 AVF and lead V1 chest lead, because the P waves are more prominent in these leads. A normal P wave in lead 2 represents atrial depolarization, which is the brown part in the picture, which precedes the depolarization of the left atrium, shown by the blue part of the diagram. So we see a combined depolarization waves of P waves with a duration of less than 120 millisecond and height of less than amplitude of less than 2.5 millimeter. A biphasic V1 P wave is seen as equal in size in both positive and negative deflection, as visible in this particular picture. An inverted P wave is seen in inferior leads, which is non-sinus in origin. So now we are seeing the aberrations or abnormalities of P waves. And here, once again, the PR interval is though less than 120 milliseconds, and origin is generally in AV junction. So this is a classical example of accelerated junctional rhythm. So if we see a P wave inversion in inferior leads as seen in this particular picture, here the once again, the P wave PR interval will be less than 120 millisecond and the origin will be AV junction. Situation will be called accelerated junctional rhythm. In right atrial enlargement, we will see the longer duration of brown part of the P wave, and its waveform extends into the left atrial depolarization. Though the amplitude more or less remains same, and the peak of R wave, the peak of right atrial depolarization is fall on top of the left atrial depolarization. So what we will see, a little taller P wave of more than 2.5 millimeter, but the duration remains normal with less than 120 millisecond. In right atrial enlargement, the peaked P wave will be known as P pulmonale with amplitude of more than 2.5 millimeter in inferior leads, that is 2-3 AVF, and more than 1.5 millimeter in chest leads V1 and V2, as seen in this particular diagram. Normally, we see a smooth contour of P waves in lead 2 and biphasic in V1, whereas in right atrial enlargement, we see tall P waves with normal duration, and in V1, we will see once again change in contour. The positive deflection will be more peaked, whereas the negative deflection will be similar, because the negative deflection reflects the depolarization of the left atrium, whereas the positive deflection reflects the depolarization of the right atrium. What are the causes of right atrial enlargement? Is generally pulmonary hypertension, which could be due to chronic lung disease, that is called pulmonary tricuspid stenosis, congenital heart disease involving pulmonary stenosis and tautology of Fallot, and primary pulmonary hypertension. So in this ECG, we clearly see right atrial enlargement with P pulmonale with P wave amplitude of more than 2.5 millimeter in height in leads 2-3 AVF. 2-3 AVF, we are seeing amplitude, that is height of P waves, is more than 2.5 millimeters. Also, the P wave amplitude is more than 1.5 millimeter in chest leads in V1 and V2. So we are seeing the right atrial enlargement with amplitude increment more than 2.5 in limb leads and more than 1.5 millimeter in chest leads. Coming to left atrial enlargement, we could now understand this is because of more of pressure or volume over left atrium, and is precursor to atrial fibrillation. In lead 2, left atrial enlargement will be represented by a longer than normal amplitude, longer, but there will amplitude remains the normal. So height of the resultant P wave remains within normal limit, but the duration will be more than 120 millisecond. A notch will be seen in P waves, which will be known as P mitral. Here we see that in lead 2, in left atrial enlargement, there is a notch in the P wave, which is representation of left atrial enlargement. And here we see in lead V1 that the deflection, the negative deflection of the P waves is more in comparison to the positive deflection, representing left atrial enlargement. So in left atrial enlargement, there is bifid P wave in lead 2, that is P mitral, which is represented by and enlargement of terminal negative portion of P wave in V1. So in lead 2, there is a bifid P waves with more than 40 millisecond difference distance between two peaks of the P waves. And the total duration is more than 120 millisecond, that is more than 3 small squares. In V1, we are seeing the biphasic P waves with negative terminal, that is later part, the deflection is more and it is more deep than 1 millimeter and more in duration with more than 40 millisecond duration. The left atrial hypertrophy is seen generally in mitral stenosis and is also seen in left atrial hypertrophy with systemic hypertension, aortic stenosis, mitral incompetence, or hypertrophic cardiomyopathy. In biatrial enlargement, obviously, both the components will be visible, that is left and right atrial enlargement, which is visible on ECG, which is either seen on in lead V1 or lead 2. So what we can expect, a biphasic P waves with initial positive deflection of more than 1.5 millimeter tall with terminal negative deflection of more than 1 millimeter deep and a negative terminal deflection of more than 50 millisecond duration. In lead 2, the bifid P waves with amplitude of more than 2.5 and duration of more than 120 millisecond. As is visible in this particular ECG, we see a biphasic P waves in V1 with very tall positive deflection of almost 3 millimeters in height and deep negative component of more than 1 millimeter deep, and duration is more than 40 millisecond in 40 milliseconds. So the criteria is met for left and right enlargement. In lead 2, we will see a tall more than 2.5. Lead 2, we see tall more than 2.5 millimeter deflection for P waves with wide, that is more than 120 millisecond duration. So once again, both the criteria are met in both lead V1 and lead 2. So this is how we understand about the bilateral atrial enlargement. Coming to the premature atrial contraction, as the name suggests, here the atria is contracting earlier than it should. So there is defect in the refractory period. The rate overall remains normal, but the rhythm becomes irregular. The P waves are premature, sometimes abnormal or hidden. The PR interval is normal or prolonged, depends on the prematurity, whereas there is no change in the QRS complex. Here the atrial rate is anywhere between 100 to 2 beats, 100 to 200 beats per minute. Ventricular rate is either same or slower depending how the P waves are entering the ventricle, the rhythm is generally regular unless until there is a
ये ठंडा
block.
खा रहा है क्या नहीं भाई? देखो
Waves differs from sinus, may be hidden preceding the T waves. PR interval is usually normal but difficult to measure. QRS is normal or sometimes widened. So this is the characteristic of atrial tachycardia. Coming to the multifocal atrial rhythm, where we see more than one morphology
तो
of
मोबाइल
T
काफी रहा है
waves,
क्या?
multiple ectopic pacemakers, either in atria or in AV junction. If there are three different wave morphology, we call it multifocal atrial
लगा दो
rhythm. As
चार्ज में लगा दो
this particular ECG,
चार्ज में लगा
the multifocal atrial tachycardia is seen with rates of more than 100 beats per minute. Coming to atrial flutter,
ये लगा
the
लो तुम
atrial depolarization is at the rate of more
लाल
than
लगा
440 times per minute, as is seen in this particular ECG. Here, the ventricular response is irregular. In atrial flutter, the atria contracts anywhere at between 250 to 300 per minute, with ventricular rhythm is also faster, anywhere between 150 to 300. Rhythm is regular in atria, but ventricular rhythm is irregular depending on the AV block. The rhythm is called F waves, and we see sawtooth pattern, आरी के जैसा दिखता है, and the PR interval is consistent or varying with normal QRX, and T wave is not identifiable. Coming to the characteristic of atrial fibrillation, we see that the rates are still higher up to 600. Ventricular rate is up to 100 depending on the AV block. Rhythm is irregular. P waves are absent with irregular F waves, and PR interval is not measurable. QRS complex though normal. Wandering atrial pacemaker, where there is supraventricular rhythm is produced with the pacemaker impulses originate from more than two sites in SA node. There is, which could be atria or AV junction, and discharge up to 100 beats per minute. So here the pacemaker is not constant. It is either atria or AV junction or the various sites and the SA node. The last, the sinus pause, where we see that the atria is not discharging or depolarizing, and therefore there is a sinus pause, and the ventricles alone are discharging or depolarizing at their own rate. With that, I would like to thank you all for your patient listening. Any questions are most welcome. If there are no
हेलो
questions, hello.
हाँ वेरी नाइस सर वेरी
Thank
एक्सीलेंट
you.
प्रेजेंटेशन सर
Thank you, Sir Ji.
वेरी नॉलेजेबल एक्सीलेंट जो
Thank
लोग को चाहिए कि हाँ हेलो बार बार चाहिए कि नहीं ये सर ये ईसीजी की जरूरत कितनी पड़ती है उसके लिए आपने इतनी अच्छी टॉक की उसके लिए बहुत बहुत धन्यवाद
Thank you so much. With that, we would like to move to the next session. So before we move to the next session, I would like to thank my chairpersons and present them with memento and certificate: Dr. Syed Akbar Ali, Dr. Alka Madam, Dr. Shalini Tomar, and Dr. S. Kumar Sir. So coming to our
थैंक यू
next
सर
session, thank you so much. Coming to our next session, Dr. Pragnesh Shah, he will be talking on importance of preventive cardiology in the current era. He is graduate and postgraduate in clinical cardiology and senior medical officer at ESIS Hospital, Vadodara. He is patron at Gujarat chapter of Indian Clinical Cardiologists and member of central body of IACC. Presently, he is president of FFPAI, Federation of Family Physicians Association of India, and honorary joint secretary of IMA Vadodara. He is also editor of FPA Beats and is on editorial team of IMA Vadodara. He has presented various papers, presentations, and he has been a speaker at local, state, and national level. He has been organizing secretary to various conferences, including IACC Con, GIMA Con, FA NetCon, FP UjCon, EcoCon, and FP Con 2014. He is founder president of Forum of Clinical Cardiology of Gujarat and member of executive body of WONCA South Asia Regional Council, and is also president of Family Physician Forum of Gujarat and FPA Vadodara. For this session, we have Dr. Bhavesh Talera, Dr. Kumud Rohan, Dr. Rajiv Mukherjee, and Dr. Rajni Chaudhary as chairpersons. They are clinical cardiologists from Ratlam, Tetalia, Uttarpada, and Dhanbad, respectively. Thank you so much. With this, I request Dr. Pragnesh Shah to kindly present his talk. Thank you so much. Over to Dr. Pragnesh.
Kindly allow me to share my slides.
Momita ji, yeah.
Yeah, I'm not able to share my slides.
Momita ji, kindly do the needful.
Hello.
Momita ji, kindly help Dr. Pragnesh to present his slide.
Sure, sir.
Monita ji, I am not able to share my slides.
Sir, have you opened the PPT yet?
Yes.
Okay. And now keep it minimized, sir.
But anyway, I am not able to share my slides.
Sir, first you just have to open the PPT.
Yes, my PPT is open and on the
And now keep it minimized, sir. And come back to the Zoom meeting. And just see, so you will get a option, share screen, the green option,
yeah, green
middle
option.
of
I
the
know it,
middle
Monita ji.
middle of the screen.
Yeah, now I can. Yeah.
Yes,
This
sir.
is visible?
Yes, sir, visible. Make it full screen.
Yeah.
Okay,
Okay,
sir.
thank you.
Thank
Thank
you,
you,
sir.
Dr. Jagnany, for an excellent cardio diabetes con on every independent day. Today, my task is the importance of preventive cardiology in the current era. Past several decades saw remarkable advancement in the science in healthcare. Does it mean that cardiovascular mortality is low? No. It means the leading cause of death are still the cardiovascular diseases worldwide. The cardiovascular diseases is eminently preventable. However, the world faces increases in cardiovascular risk factors. The overweight and obesity, type 2 diabetes, and metabolic syndromes are the main factors. Poor long-term adherence to the healthy lifestyle and life-saving pharmacotherapy have exacerbated unprecedented increase in cardiovascular morbidity and mortality. So how we can define the preventive cardiology? Preventive cardiology is a proactive patient-centered approach in which the clinician or team of clinicians and non-clinical assess cardiovascular risk and implement a comprehensive strategy of risk mitigating to prevent cardiovascular disease and its clinical sequelae. So, as we all know, for the preventive cardiology, we all must know the cardiovascular anatomy and physiology, cardiovascular rehabilitation, sex and race or ethnic group specific risk factors, genetics, pharmacotherapy, metabolism, imaging, and lifestyle management. Now, what is the scope of the preventive cardiology? So let's start with the primordial prevention. The risk factors like sedentary lifestyle, obesity, sleep, diet, smoking, hypertension, dyslipidemia, CKD, metabolic syndrome, diabetes, female-specific factors, psychosocial stress, and inflammation. These are the primordial prevention. These are the risk factors which we can prevent and to participate in the primordial prevention. The primary prevention, it means there must have a first event for the clinical disease like MI, heart failure, peripheral arterial disease, stroke, or sudden cardiac death. And we have a secondary prevention at where already there are recurrent major adverse cardiovascular event. So today primarily I will restrict myself on the premortal prevention as to restrict with the time. Premortal prevention is the prevention of the risk factor for the cardiovascular diseases. Approaches should be covered determinant of cardiovascular risk, to the environmental health risk, to the social health risk. Now, we all know that atherosclerosis may begin in the childhood at the age of the 2 to 3 years. As the autopsy of the individual from the age group of 2 to 39 years found that every individual had evidence of fatty streak in the aorta. Half of the children between 2 to 15 years old had fatty streak in their coronary artery also. The Bogalosu study said that. So prevention of the cardiovascular disease should begin early in life with the establishment of the healthy lifestyle. So primary prevention is the aggressively management to prevent the incidence of cardiovascular disease events. So we all know the life essential aid, which represents an example of a useful construct evaluating modifiable risk factor for the individual patients. These all life essential 8 risk factors are which we can modify, like nicotine exposure, body mass index, physical activity, diet, blood lipids, blood pressure, blood glucose, and sleep. These all are the very important factors. If we can control this, we can prevent the incidence of cardiovascular disease. In the primary prevention, attainment of the ideal cardiovascular health at 50 years of age is associated with the substantially lower lifetime risk, 5.2 versus 68.9% in men and almost 8% to 50% in women. Longer survival, more than 11 years in male and more than 8 years in female. Increasing number of ideal cardiovascular health metrics are associated with lower prevalence and incidence of atherosclerotic cardiovascular disease, atrial fibrillation, heart failure, and non-cardiac condition like cognitive impairment, depression, and cancer. Risk factor control earlier in the life course is associated with substantially larger morbidity, free survival. Now, the secondary care aims to reduce the disease-related event among individuals with established CVD. Prevalence of cardiovascular disease remains one of the strongest risk factors for subsequent event and mortality. 5-year rate of recurrent myocardial infarction, stroke, heart failure, and cardiovascular death is between 20 to 30%. It's a big chunk. And there are 4 to 5-fold increased risk when compared to the individual without prevalent cardiovascular diseases. Understanding risk category help further optimizing care with the pharmacotherapy and lifestyle modification to prevent the cardiovascular death events. Now, as we all know about the Framingham study. In the Framingham study, multiple risk factors of cardiovascular disease are included, like cigarette smoking, high blood pressure, high cholesterol, obesity, physical inactivity, and type 2 diabetes. And from that score, we are able to give 10 years disease risk to the person. The Framingham studies established the multiple risk factors are responsible for the development of cardiovascular diseases rather than just single factors such as LDL. So the abnormalities of readings of the following conditions like lipid, inflammation, cardiometabolic disease, diabetes, hypertension, CKD, and thrombosis, they all combinedly increase your cardiovascular disease. About the lipid, the discovery of LDL receptor and its role in lipid metabolism helped spark a concerned interest in the effects of lipid-altering medication on the cardiovascular outcome. When it comes to LDL, lower is the better is the dictum. Statin therapy become the standardized lipid-lowering risk-reducing medications. Special attention should be given to familial hypercholesteremia given its high prevalence affecting roughly 1 in the 220 individuals. About the metabolic syndrome, we all know that is defined by the group of the risk factors underlying metabolic and cardiovascular diseases. And clinically, this condition is diagnosed when more than 3 criteria meets. We all know this all these three criteria. And metabolic syndrome not only increases atherosclerotic risk, but can also lead to multiple organ system dysfunction. We must remember this. For the CKD, it's the sequelae of the long-standing hypertension or uncontrolled hypertension and contribute independently to atherosclerotic cardiovascular disease, arrhythmia, and sudden cardiac death. CKD persists. CKD means that persists EGFR less than 60 or urine albumin to creatinine ratio is more than 30. We all know that. Blood pressure management is a challenge as the rate of hypertension control have declined over time to staging. Albuminuria and proteinuria, common sequelae of the hypertension and type 2 diabetes that independently increase the cardiovascular risk, often unrecognized and untreated. Now, about the thrombotic risk, aspirin is for the primary prevention of the cardiovascular disease. We have to judge the cardiovascular benefit versus the bleeding risk. For the cardiovascular benefits among the individual, if their calcium, coronary artery calcium score is more than 100, they will definitely give benefits. Now, we all know about this CVD risk calculator, the famous Framingham score. We have to enter all this data on the auto calculator like age, HDLC, cholesterol, your systolic BP, you are smoking or not smoking, your diabetic status, your hypertension status. And after adding all this data, the calculator will give you risk. And all these factors have a different point. But the important thing is that if your risk score is high, it means more than 20%, consider treatment to all. If your risk score is high, then you have to treat all the persons. If you are at intermediate in the risk score, it means 10 to 19%. So you should treat the risk factor. And if low, generally no statins are indicated. So this is the calculator on which you can enter your data and you will find your risk score. So what are the guidelines for primary and secondary preventions? Once there is a cardiovascular disease is already established, if the risk score is low, the lifestyle intervention is the guideline. If you are low to moderate to in the risk score, blood pressure control, cholesterol control, glycemic level control, reduce your obesity, stop the smoking are the step you have to take on. And once there is already established disease, then pharmacotherapy like beta blocker, SGLT2 inhibitor, statins, ACE inhibitor, and oral antiplatelets are the way to treat the high risk and very high risk population. So this is very clumsy side. I will not go in that. But heart healthy diet includes emphasis on whole grains, fruits, vegetables, legumes, nuts, fish, and seafoods. Refined carbohydrates, processed meat, and sugar sweetener beverages should be minimized. Trans and saturated fats should be replaced with dietary mono and polyunsaturated fats, and reduction in sodium and cholesterol are also encouraged to reduce the cardiovascular risk factors. The regular physical activity has been shown to improve and area of the cardiovascular and metabolic risk factor and reduce the risk of many forms of cancer. We all know this, so I will not go and discuss in this. The Jupiter trial also says that 50% reduction in LDL cholesterol level and 44%, it will reduce 44% reduction in the primary endpoint of all cardiovascular diseases. Now, as I already told you, I will only speak on the primary prevention, so I will not speak on that secondary prevention. So to summarize, world faces increase in cardiovascular risk factors, overweight, obesity, type 2 diabetes, other metabolic syndromes. So poor long-term adherence to a healthy lifestyle and life-saving pharmacotherapy increases the cardiovascular morbidity and mortality. So scope of preventive cardiology covers primordial prevention, primary prevention, and secondary prevention. According to me, prevention is better than cure. So we all have to act on the primordial preventions. We also have to consider all the leading risk factors like cigarette smoking, high blood pressure, high cholesterol, obesity, physical activity, and type 2 diabetes. And I would like to add one more risk factors like consumption of the drugs, like morphine, ganja, and the other new drugs available in the market. So government has to be strict on that policy and restrict the youth to consume the drugs. Then abnormality leading to the cardiovascular death, like hypertension, CKD, dyslipidemia, inflammation, and thrombosis. We also have to act on these all conditions to prevent the cardiovascular mortality and morbidity. So thank you, friends. Thanks a lot for your patient hearing. I would like to answer if there is any questions.
Thank you so much, Doctor. That was a very lucid presentation on preventive cardiology. I would like to get into few things like we have talked about primordial prevention, primary prevention, secondary prevention. So where do we see antiplatelet agents while we are talking about primary or primordial or secondary prevention?
See, I already told that if there is no bleeding risk or there are the benefits, it's more than the risk, or the calcium score on coronary angio or in the coronary scan is more than 100. The benefits to give aspirin is improves the general health, and it will prevent to develop the coronary or atherosclerotic events. If the calcium coronary score is more than 100, then we can give the aspirin. And about to prevent the stroke, there is no specific guidelines, but if the no allergy to aspirin or no bleeding tendency, and patient is high risk with the diabetes and dyslipidemia and hypertension, you can give aspirin to prevent a severe stroke.
So we can say that if there is more than one risk factor, it can be a good idea to add a low dose aspirin, which will help to prevent the cardiovascular diseases or promotion of atherosclerotic event. We can say like that.
Yes,
Maybe
we can.
Single risk factor we may
Yeah,
need
single risk factor, there is no need to start the aspirin.
And do we see any difference in uses of two different types of antiplatelets? Like maybe one class is aspirin and another is like either ticagrelol or clopidogrel. So is it only the what we call allergy part, or is there any difference when we talk of aspirin while comparing the other antiplatelets like ticagrelol or clopidogrel?
There is nowadays there is a 30 to 40% resistance to aspirins. So we also have to consider that part. And now there is no data on the ticagrelol in the prevention, but some studies suggesting of use of clopidogrel instead of aspirin in preventive after considering the bleeding risk.
And do we see any difference when we talk of any particular class of drugs? Say we talk about statins. So we have atorvastatin, we have rosuvastatin, simvastatin. So many statins are there. So do we see any difference in any of these, or an appropriate dose of either of these statins will be equally helpful?
See, basically it is a class effect. It is a group effect. So atorvastatin and rosuvastatins, both are equally good, but the all studies, most of the studies are on the rosuvastatin groups. So there are less study about the atorvastatin, but according to me, it is the statins. It means it's a class effect. So you can give atorvastatin or rosuvastatin for the primary prevention.
Exactly. So, any other question for Dr. Pragnesh? I guess that was a wonderful presentation. Doctor, any other questions?
I think there is no question, so we can proceed to the next session also.
Thank you. Thank you so much. Thank you, Dr. Pragnesh and our chairpersons for being here. Rajni ma'am, any comment from your side?
Nice presentation. It was a very nice presentation.
Thank you. Thank you so much, ma'am. A token of appreciation for our speaker, Dr. Pranesh Shah, a memento and a certificate. Also our chairpersons, Dr. Bhavesh, Dr. Kumud, Dr. Rajiv, Dr. Rajni. Thank you so much. Moving ahead, somehow very sorry to say, due to some urgent situations, some of our lectures are cancelled, some have health issues and some other issues. Something has come up. So our next session with Dr. Bharat Purohit, Dr. P. Mohan has been cancelled. We are straight away right now moving to Dr. Madhav Bansal, comprehensive assessment of CV risk factor profile and visual depiction. It's interesting that he has his own study, and we are privileged that he has agreed to prepone his presentation. So moving ahead to Dr. Madhav's presentation. I'm really thankful to chairpersons who are here, and I'm really sorry that some of the lectures are cancelled due to unavoidable situation. Dr. Madhav Bansal is a clinical cardiologist from Bhopal. He is recipient of Young Scientist Award from ICMR for functioning of sub-health centers in Mandala. He has been part of project like CV risk factor profile, visual depiction using a spider web chart, and he is here for this presentation. He has various publications to his credit. The chairpersons are Dr. Prerna Chetri, Dr. Rakesh Chaudhary, Dr. Anurag Jaiswal, and Dr. Vaibhav Jain, who are clinical cardiologists at Tadong, Jaipur, Jamshedpur, and Dr. Vaibhav Jain is at Gurugram. He is also research fellow at Mayo Clinic, and various publications, presentation, research grants, awards, and speakers to his credit. He is member of various societies. So with this, I really thank and request Dr. Madhav Bansal to take from here. Over to Dr. Madhav Bansal.
Thank you, Dr. Jagnany. Let me share my screen. So this is basically I have done a small pilot study on a new tool which I have developed to assess the profile of the patient, cardiovascular risk factor profile of the patient, and visually depicting it using a spider web chart. I am presently working as associate professor in the Department of Community Medicine, Gandhi Medical College. The objective of my study were to develop a CVD risk factor profile index by integrating the different modifiable risk factors and to visually depict the CVD risk factor profile of patients using spider web chart, and to compare the profile of patients in patients with and without cardiovascular disease. So basically, this tool, there is a need as I mean, currently the lifestyle diseases or the cardiovascular disease are the major cause of morbidity and mortality worldwide. We need different strategies to control these risk factors. And this study and this tool is an effort to have a better picture, better profiling of the risk factors individual for better management. I'll be detailing about the tool in the subsequent slides. In this study, it was a pilot study in which it was a cross-sectional study done at Urban Health and Training Center under our department at the cardiology ward over a period of 2 months. And the study tool was the cardiovascular risk factor profile assessment tool. And there were 30 patients with cardiovascular disease taken from the cardiology ward of Hamidia Hospital, GMC Bhopal, and 30 patients without known CAD or any symptoms of CAD from the Urban Health and Training Center. Sampling was a convenient sampling. And patients with CAD were included stable patients and patients who had non-coronary artery disease like rheumatic heart disease or congenital heart disease were excluded. And patients who fit the inclusion criteria were administered the CVD risk factor profile tool for their assessment. And the tool was explained to the patient. Patient was counseled on healthy diet and lifestyle. Coming to the tool, the new CVD profile tool, which I have developed in the last 1 year. Basically, these 10 conventional risk factors I have taken in the tool. Body mass index, tobacco, diabetes, hypertension, alcohol, and also I have taken excess refined food as also a factor in the scoring, and poor intake of protective foods, that is fruit, salads, sprouts, and vegetables. Also, I have taken in scoring in this tool. Stress, of course, is a factor, lipid profile, and physical inactivity. And protective risk factors were physical activity, yoga and pranayam, adequate intake of fruit, salad, sprouts as per the WHO guideline, and meditation. Now, this tool quantifies each risk factors of cardiovascular disease on a scale of 0 to 5. And the score of all the risk factors are added to obtain the total score, that is risk factor profile index. So every factor is scored on a scale of 0 to 5. I have a few examples to show. I'll also show you the entire tool. So there are 10 risk factors. Each patient gets a score out of 50. And of course, certain risk factors are protective if they are present in adequate quantity, like physical activity is protective, and if it is absent, it is a risk factor. So protective risk factors have also been considered, and they have been given a negative scoring. And the negative scores are combined to obtain a negative, protective risk factor score. Now, this is one example of scoring of diabetes. So, like 0 has been taken as no diabetes, 1 for pre-diabetes, 2 for good control, 3 for inadequate control, 4 for poor control in terms of HbA1c. If the HbA1c is between 8 to 9, it is poor control, and if it is more than 9, it is very poor control. The score has been given as 5. So, in the literature, in the scientific literature, what is considered as very high or high has been taken as a score of 5, and something which is normal value has been taken as a score of 0. And in between, the scoring has been distributed based on mild, moderate, or level of severity. Like there's another example for obesity. So normal has been taken as 0. Mildly raised BMI has been taken as a score of 2. 1 is not taken over here. Moderately raised BMI, that is between 25 to 27.4, has been taken as a score of 3. And between 27.5 to 29.9, the score is taken as 4. And more than 30 is 5. So result of the tool can be depicted in 2 ways. One is the risk factor profile index, and the other is spider web chart. So this is the spider web chart on which the visual depiction of the profile is done. And this is a hypothetical example I'm showing. So this is how the spider web chart, the profile of the patient appears. So the smaller this web on the chart is, the lower the risk of the individual, the bigger the web, the higher risk factors the patient has. So this is giving a visual depiction. And at a glance, you are having a profile, a comprehensive picture of the profile of risk factors of the patient. And this is similarly for protective risk factors I have taken. So basically, the purpose of the tool is gives the patient as well as the physician a comprehensive picture of the patient's CVD risk profile. And the idea to have an idea of the degree of different risk factors in the individual at a glance, at just a glance. By viewing the spider web, you can have an idea. It will save the time of the physician. It will help the physician to impart better and more specific diet and lifestyle changes. Patient will also have a greater awareness of his risk factors, a visual memory, visual picture of his risk factors, which are then the individual and to what extent they are in him. And this will help to monitor the change in his risk factor profile on subsequent follow-ups. So in other words, it will act as an educational tool for the patient also. Coming to the, I'll be showing you the tool as well. Coming to the study, these are the age distribution of the patients who were taken in the study. This is the risk factor score of the individuals. So the risk factor score has been categorized into a low score having a score of 0 to 9, a moderate score having a score of 10 to 19, high score having a score of 20 to 29, and very high score if the score is 30 or above. So what I found is the majority of the patients were in high score is 20 to 29 category. And of course, this was significantly much more for patients with CVD, and it was less for patients without CVD. So the risk factor score, the risk factor profile index was obviously it was higher for patients with CAD, and it was lower for patients with without CVD. Now this is similarly for protective factor score of individuals. So patients who were having, I mean, it was categorized as 1 to 5 as low score, 5 to 10 as moderate score, 10 to 15 as high score, and minus 15 to 20 as very high score. So patients without CVD, blue line, they were having higher scores. If you look at the 15 to 20 score, there are more patients without CVD who are having this high protective factor score. And also in the same case in 10 to 15 category. So this is the actual real example of a patient whose profiling was done. We can see it is a big, relatively big web, and comparing it with another example of a patient, it is a smaller web. So his profile is relatively better compared to this patient, previous patient. And of course, this can also be used not only to compare patients, but to see the change over a period of time in the same patient by repeat assessment. There's the limitations of this study and the tool. The one thing is, the most important thing is the tool does not calculate the risk of any acute event. Because most risk profiling books, factor assessment tools try to calculate the risk. This does not calculate the risk. The purpose is to have his picture of his profile at this point of time, because risk calculation requires an altogether a different approach in which many other things have to be considered, like for smoking, for how long he has been smoking. So there are many other issues. This does not calculate the risk. And the tool requires a long time to assess the patient's profile. Okay, and of course the tool requires training for using the tool, because tool is very elaborate and very complicated. and without training, it cannot be taken up by somebody. So the study concluded that the patients who had CAD had higher risk factor score, risk factor profile index, whereas patients without CAD had a lower index. Now let me show you the tool. Let me show you the report of the tool first. How we report the tool. So this is the report. Here we give the risk factor score of the individual out of 50 what is obtained, and the limitations has been depicted here, that low score does not indicate low risk. This tool score does not give the risk of any acute ischemic event. The tool only quantifies and visually depicts the risk factors present in the individual at the time of assessment. We see here in this, it will be depicted the profile of the patient, and similarly the protective factor profile of the patient will be depicted here. Now coming to the scoring system. So BMI I told you, and for smoking and for tobacco chewing, this is how it has been done. Like 1 to 5 cigarettes. It is in the scientific literature says that there is no amount of tobacco use is safe. Even the lower consumption, like just 1 to 5 cigarettes per day, have been associated with more than twice the risk of any cardiovascular acute event. So the scoring has been started from the low level, 1 to 5 per day.
So sorry, Dr. Madhav, but your screen is not visible.
Okay. Let me see.
Sir, screen is visible but not appropriate.
Yes.
Okay.
Yes.
Momita, kindly help Dr. Madhav.
Is it visible now?
Yes.
Okay.
Now we can see your chart. Thank you so much.
Okay.
If you can make it full screen, Dr. Madhav, that will be helpful.
Sir,
Sorry?
is it possible to make it full
If you could
screen?
make it
Full screen.
Is it in PPT?
No, this is a Word document. How can I minimize the ribbon? Okay. Is it fine now?
Yes, sir.
It is
Yes.
visible. Okay. So smoking has been taken, tobacco has been taken, like, because the scoring has been started right from the very low level, because we have not tried to go to the very high level as 5. The risk is significant enough if the smoking is more than 11 or more cigarettes a day. That has been taken as a high level. Similarly, 5 or more times in a day for tobacco chewing has been taken as a high level, and a score of 5 has been given. And now suppose some individual is doing smoking is also there, and he is chewing tobacco also. In that case, the scores are of both the things are combined, and the score is more than 5, then the score of 5 is taken. Suppose the total is 6, the score of the individual will be 5. So maximum score is 5. Diabetes I already showed you. Similarly, for hypertension, I have taken based on American Heart Association and European Heart and JNC criteria. I have categorized them and given a score from 0 to 5. Alcohol, similarly, based on NIAAA, National Institute of Alcohol Abuse and Alcoholism in the US. Based on those guidelines, I have categorized this.
Madhav boss,
Yes.
KDI here. बॉस ये आप F11 दबा के फुल स्क्रीन करने की कोशिश करिए ना.
F11 ये फुल स्क्रीन ही है. मेरे स्क्रीन उस पे तो फुल स्क्रीन ही है.
ओके सर.
तो Now, I have also taken excess intake of refined food as a risk factor, and that has a detailed scoring has been done. Has to be done for that. So, what are the different possible unhealthy foods that we consume? All have been taken into the chart, and the frequency in the last 1 week has been assessed, and the details and the portion part, what portion has to be considered as one, what quantity has to be considered as one portion has been given in the side table for different biscuits and everything. Based on that, we calculate the portion of whatever patient has consumed, and then we total it. So whatever the total score comes, then that score is scored for our profile. Suppose if he is consuming those unhealthy food items more than 12 portions in a week, then the score is given as 5. And if it is 10 to 12 portions in a week, it is 4. So this is how it has been scored. Similarly, intake of vegetables and fruits has been scored, and whatever the WHO suggests that it should be at least 5 portions per day of vegetable, fruits, or sprouts to have a protective effect. So 5 portions has been taken as -5. If he is taking 4 portions in a day, it has been taken as -4. And if he is not poorly taking not even once in a day, then it becomes a positive score. Lipid profiling has also been done, and in this total cholesterol, LDL, and triglycerides has been considered. And scoring for all the three is there, and the maximum score is taken as the maximum of either of the three has been is taken as the score of the individual. Similarly, for stress, a perceived stress scale is there, 10 points, in which there are 10 questions. So patient is administered that scale, and his stress level is assessed, and based on the score of the perceived stress score, which is given here, patient score for stress for the tool is given. So similarly, for physical activity level has been done. A lot of work has been done, but a lot of literature review was done for scoring this. For like vocational physical activity, if it is moderate to intense, then the score of -5 or and -3 has been taken. Otherwise, in literature, there is no protective effect of routine physical activity or less than moderate intensity physical activity. So if at all it is there, then the score has been taken from 1 to 3 kind of that. And if there is no activity, score of +5 has been taken. Housewives, the work of females housewives has also been considered, but the literature does not say that it is protective. But of course, if it is there, female is doing significant amount of household work, it has not been neglected in the tool. If she is not doing anything, she is given a score of +5. But if she is doing some activity, household work, depending on the degree and the duration, a score of 3, 2, 1, it decreases. The positive score decreases. So brisk walking, morning walk, jogging, running, all these have been taken into considered. These are the protective factors score. So my negative scoring is taken for them. So these all the risk factors are then meditation has also been taken, yoga pranayama has also been taken the protective factor score. And then all the risk factors are combined to obtain a total score for the risk factor score, similarly for the protective factor scores. So physical activity here is combined for all forms, maybe vocational, non-vocational, or household level, whatever it is there, that is combined and the score is obtained. Of course, the score is how the scores are obtained, how the different components are combined requires further detailed explanation, which won't be possible at this point of time. So this was all about my tool, in which I am also planning to digitalize. So So if somebody has any questions, and also I would like to have your opinion on the tool. Thank you.
Dr. Bansal, thank you so much for this wonderful presentation. I'm really sorry I joined a bit late, but where I joined, it looks amazing. So the thing is, we have to validate this with various other available scores. So you might be aware of QRIS score, which is available in the UK, and previously the Framingham score and ACE score. So what I found different in that is it's more related to the Indian population. So all these scores previously which were available, they were not as, especially for the Indian population, that's what we need to cater. Because Indian population, as you know, especially the South Indians, have more risk factors. One of the things which I found here was just for the cholesterol levels. And uh, there are several studies now that in Indian population, LDL is more riskier, especially further forms of LDL. And I think that could also be included in this to see what results they change, or whether there's an impact on the risk factor scores on that. So that could be one of the possibility we can make it. And obviously the sample size could have been increased a bit to see how this response on a more general population and in the different age groups. Now, since we know that, yes, CAD is more growing towards young, so that's the more point of concern these days. So can you just help me with what was the definitely different proportion of age group, what was included in your study, so that which group will benefit more from this risk score?
Actually, see, it is this is the age distribution.
Yeah.
And the one thing which I want to stress upon is this factor, this tool does not assess the risk of the individual. So it is not something which we can compare with Framingham heart score or any other score, European scale or something, because that is entirely a different thing, assessing the risk of the individual. This is just profiling the risk factors of the patient.
Yeah.
So that for better control, he is better, more aware of it, and he is able to better control it. Because the assessing risk will also, for example, if we take diabetes or smoking, if we want to assess this, we'll have to consider for how long he has diabetes, whether it was well controlled, poorly controlled, for how long he had been smoking. So all these factors, that is a very complex thing to assess the risk of the individual, and that is entirely not the purpose of this tool. The purpose was to just profile the patient for better management.
Right, right. No, I completely understand that point, probably. So that's a very good point, actually, that a patient is well aware of his symptom, his score, so that he can adjust to it more accordingly to. No, that's a very valid point.
Yeah, I mean, I suppose somebody has a score of say 10 and somebody has a score of say 25.
Yeah.
We can also figure out, a physician as well as the patient can figure out where he stands, and of course at the spider web chart, the visual depictions also, the visual memory the patient is having. So that appears to me that it could be a tool of a very helpful tool in the clinical practice.
Right, of course. Of course. So everyone, when you practice in the cities, everyone wants to know that, yes, what is their risk of getting any heart disease, or what is, suppose they have their one of their family members who have some sort of a CAD or ACS, and then they're definitely interested in, especially the preventive health checkup, when they came to the preventive health checkup, what's their risk of getting a disease? So this tool could be useful in that as well. So as a part of their lifestyle management, giving them just a kick that, yes, they have to take care of their lives as well.
Yeah, definitely. This tool can be part of preventive health checkups, actually. Can be a part. But the only thing is it requires some time to, fill this tool, because it requires a lot of information.
But these days, with all these EMRs, already we can inculcate this with the EMR and all this. Most of the data can be pulled up from there. So without much of manual effort, I believe. But the thing is, before proceeding, maybe it's a good idea to increase the sample size and see how the results goes. So before getting into the clinical practice, so that's what I think
Uh,
could be done.
yeah, this was a pilot study to test the tool, basically how it works and what are the problems that we encounter in
Yeah.
this tool.
Yeah.
That was the basic purpose of this pilot study.
Yeah.
So for us, further studies are being planned.
Definitely. Definitely. Oh, that's a very valid point. I completely agree with you. Any thoughts from you, Dr. Kedia?
Nothing, sir. That presentation was marvelous. I am already listening. Thank you, Dr. Madhav.
How is your what is your opinion about this tool, Manish? Dr. Manish, how did you find the tool? Hello, Manish. Okay, anyway, I think he's got disconnected. So thank you very much.
I must say that this is, it looks like a novel idea, though we all know that these are the risk factors, we all talk about it, but putting it in one particular place and presenting it in such a lucid manner, and also this visual depiction of the same thing in just two charts, two pictures more precisely, the red picture and the green picture. I guess this is a wonderful idea to, on the part of the patient specifically, that he can understand that where does he stand. If we talk about the red picture, the red spider web, the outer side he is probably is at a greater risk, and there he need to work on whatever things is missing, maybe weight, maybe physical activity, maybe the food intake, about the sprouts, the tobacco, alcohol intake, or the stress. So it's quite clear from this particular study. Definitely, I agree with Dr. Vaibhav that if we have a larger sample size, if we have more number of individuals taken into consideration, this will have definitely a greater value, and we will have more wider use amongst clinicians as well as the recipient, that is patients, and that will be definitely much more helpful. Interestingly, the most of the data which you are picking up here does not involve much of the finance, and it is like more of his food habits and his lifestyle. And probably we have been talking about this a great in preventive cardiology, even in the previous talk from Dr. Pragnesh Shah. So we all are clinical cardiologists, and we talk more about prevention rather than doing plasty and pacemakers. So definitely, I must appreciate and congratulate Dr. Madhav and his team for designing such a tool for clinical assessment of the individual about the risk factors. And definitely, it will be helpful in knowing about themselves, and so that they can work further to make themselves healthy. So, hearty congratulations. And to be a little greedy, Dr. Madhav, I will send you my email ID. Kindly mail this, if you are comfortable, kindly mail this presentation to me. So that will be a help to me, definitely. If you are comfortable, Dr. Madhav.
Definitely. And once I develop a digital version of this tool, I'll be sharing. I mean, I'll launch it. I'll share it with everyone.
Thank you. Definitely. Any other comments or questions for Dr. Madhav?
Yeah. Best wishes, Dr. Madhav. Thank you so much for this wonderful presentation.
Thank you. Thank you.
More and more people are asking for your presentation. Dr. Manish has put his email ID for your presentation. So we all look forward to it.
Sure.
So
sure, I'll definitely share the presentation.
Thank you. Thank you so much. Any other questions? Any other comments for Dr. Madhav? In that case, we can move to our next talk. We're requesting Dr. Madhav to kindly stop sharing his slides so that we can move ahead.
I have stopped sharing.
Momita, kindly help.
No, sir, no.
Okay, stop share now. Okay,
Yes.
fine.
Yeah, thank you so much. So that was a wonderful presentation from Dr. Madhav Bansal. Kindly accept the certificate and the memento. This will be reaching you by post shortly. Also to Dr. Rakesh Chaudhary, our chairpersons, Dr. Prerna Chetri, Dr. from Tadong, Dr. Anurag Jaiswal, and Dr. Vaibhav Jain. Thank you so much for chairing this session. Moving on to the next session with Dr. KP Singh. He is here and his presentation will be unique in the form that he will not be having any slides to present. It will be more of a open discussion on clinical diagnosis of acute coronary syndrome. Dr. KP Singh is a graduate, postgraduate, and diploma in clinical cardiology. He is also a lawyer, he's sonologist, and presently he is working with medical college. He has been working at Medanta. He's life member of various associations, including IMA, Delhi Medical Association, Indian Academy of Echocardiography, Delhi Diabetic Forum, also member of forensic medicine in various associations. To chair this session, we have Dr. Sudipta Sinha, Dr. Munir AR, Dr. V K Jagnany, and Dr. Tani Patel from Kollam, Ranchi, and Vadodara. With this, I hand over the session to Dr. KP Singh for his further presentation.
Thank you, sir, so much. Warm welcome. Happy Independence Day. Thank you, Dr. Jagnany, for inviting me for this very interesting and daily bread and butter topic of the PGDCC or any cardiologist. That is our practice is starting with this clinical finding chest pain or discomfort. Whenever is there any patient visit our either a OPD or in the emergency, the main problem is chest pain, or we can say in our words as the angina or any discomfort or any follow-up patient of the diabetes, hypertension. All the risk factors have been already explained by Dr. Madhav Bansal and previous speaker Dr. Parnesh Shah. So my topic is already easy by previous speakers. So the acute coronary syndrome is the bread and butter of each and every clinical cardiac physician or a cardiac surgeon or cardiac interventional person. So this is the very looking easy topic, but it is not the easy. There is so many days can be spent over the discussion of the acute coronary syndrome, because each and every topic is widely can be studied. And since 1980 in India, these patients raised, study was going on in the OPDs, All India Institute and other Indian institutes were raised the patients slowly and gradually, and then become the flood of the acute coronary syndrome and complications. And so then the PGDCC was born to prevent the disease and minimize the complications of the cardiovascular disease and their sequelae and complications. So this is the very important. We should not miss any patient. We should guide, we should treat, we should understand the pathophysiology of acute coronary syndrome. Because if we miss a patient, we miss a lot. Not only we can play with the life of the patient, we also get the change in status and dignity of our profession. So everybody should take precaution now these days era of doctors are always in the risk, because previously people were say doctor is a bhagwan, but now we are under the Consumer Protection Act. So every client, now we call it a client, not a patient. So we should take precaution. Whenever we treat the patient, we should be politely, gently, beside then a diagnosis or treatment. Because as Dr. Jagnany has explained about me, something told about me, that I am a forensic person. So I request humbly my all the colleagues, those who are listening here, we should be as humble as possible, because in acute coronary syndrome patient, attendants are much more excited. What happened to him? डॉक्टर साहब ECG हुई, क्या हुआ है इसको, कहीं हार्ट अटैक तो नहीं हुआ है? जो हम नहीं कह पाते उसके अटेंडेंट पहले से ही बोल रहे होते हैं. Sorry, I think everybody can understand in my local Hindi, because mostly patients are very curious, and sometimes they, as I have a long experience of attending emergency in the hospitals, so patient, attendant, relatives, friends are very much curious about what happened to him. As soon as the patient, there we have three tools in emergency or in our OPD. One is the ECG, second is the echo, third is the drops, or we can say cardiac enzymes. So we have to decide the patient is cardiac or non-cardiac. As soon as we get done the ECG, so patient asks, what happens to me? Beside the history, we see the ECG. Is there any change in ECG or normal ECG? If there is no change, then we ask the patient for observation, minimum 6 hours, and serial ECG during the stay of the patient. And then second step is, because we mostly have standby echocardiography machine, so we should see the regional valve motion abnormality. If there is any fresh change in ECG, or is there any findings in our echocardiography, then we suggest the patient that he should admit for further evaluation and further management according to the need of the hour. And these days we see the patient, either it is a running patient or cash patient or any TPA, or is it covered by any insurance company. So next is our test is troponin. There are so many troponins are available. Quick trop T, troponin serial. As soon as we go through these tests, we decide. And fourth is most important is signs and symptoms of the patient. Is patient have acute chest pain? Is there a severe chest pain? Patient is controlled by ordinary medicines, painkillers or not? If the patient is not, if ECG normal, cardiac enzymes are normal, echo normal, and there is no relief in the pain, then we ask the patient, it may be a acute coronary syndrome under the non-ST elevated. After the observation, if the patient is agree and consentant, giving the aspirin, clopidogrel, or any other relevant medications according to the situation, we can put the patient either immediately or the next day. If a patient come in the night, if interventional facility available, in according to the situation, we can also plan the patient for the angiography. But in other case, if the patient get relief and there is a no, then we can discharge the patient after suggesting to come up in the OPD for the further evaluation and we can get further TMT or stress echo to rule out the disease. If there is change in the ECG or change in the echocardiography, we can plan a patient for subsequent investigations and evaluation or interventional or preventive checkup or preventive follow-up. So this is the, in short, according the ECG, echo, and troponin basis, our cardiac patient management in emergency and evaluation. So I want to stop here. If there is any questions, you can ask me, because I have not prepared any slides, because sorry, I forget the topic. So I want to say these words in short. Thank you so much.
Dr. Singh, that was really interesting. So, and that's the everyday thing we require, because that's the thing which we are dealing with every day in ER or in OPDs or even in clinics. So one of the important thing which I think is also important is about the history. So what's the patient is telling apart from ECG, echo, and the cardiac enzymes. So it's all as a history as well. So what sort of symptoms he is complaining, what sort of chest pain, whether looks like a typical chest pain or an atypical chest pain, whether does he have exertional symptoms, what does he have other risk factors for having a disease, maybe a diabetes, hypertension, or he's a smoker. So that also makes important criteria to have anything, because when you see the most of this time what happens in the ER, so freshers or anything, they just for every sort of chest pain, whatever it is, you get a cardiac consult in the night from the ER specialist. That yes, whether it is a pain in here, whether in the left arm, or whether every call you get as a cardiac specialist as a angina pain. But we have to differentiate in important sense whether this is actually cardiac pain or is it something atypical pain. So in that case, it becomes more important. Like, does he complain of any sort of breathlessness along with that? We have to rule out those things. ECG, echo just aid us in making our diagnosis at that point in time, which I feel. So what's your thought about that, Dr. Singh?
Yes, we have to, there is a no doubt that we have to evaluate patient since the chest pain and the past previous histories as the most important part of treating the acute coronary syndrome patient.
Right, right. Because many patients, sometimes they just get, for young patients, I've seen a couple of young patients who is in their 30s or 40s. They don't have any history, but had a couple of drinks last night, and then they're complaining of chest pain. So what happens? They get admitted in the night, and then tomorrow morning, someone will do a cath for them. So it happens many a times, you know. So that's the reason I feel history is more important than just in his ECGs doesn't showing any much changes. It's and troponins is also the same, but looking at the history, he had some chest pain he got for cath. So probably there would be, as we were discussing in the previous session, that these tools, some sort of these tools can help in differentiating whether it's a cardiac pain or a non-cardiac pain. And obviously, echo is our best friend. So though the separate issue of PNDT, but it's our best friend, which can help in seeing a regional motion abnormality at the right point, or differentiating with pericarditis or anything like that. So really interesting to know about ECG, echo, and cardiac enzymes, which are best tool.
Yes, sir. Thank you, sir. You have elaborated very well. And previous speaker, doctor, have explained all the systemic in the scenario of the our cardiac disease. And not only cardiac disease, we also prevent the patient from cardiovascular accident, CVA. And there are so many patients which are suffering with diabetes and suffering with hypertension and thyroid disorders. Also, we covered it in and prevent the patient from further complications. So this is the, we are the in the hospital champion of the doctors. Whenever there is a patient present with any other disease, especially I had worked in Delhi NCR, patient with the CVA or patient with any other disease, they always call, one call must come for the a cardiologist on the emergency duty, if there a patient is planned for the cesarean, एक बार ECG दिखा लो. So patient, you are always on call. There is a no night or day duty. Can't go without any attending so many patients. Not so. Every time we should be ready to. It patient should not be, because sometimes there is a no symptoms or atypical symptoms after the COVID. There are so many pathologies. Even jo interventional cardiologists are surprising, because just patient coming, just a difficulty in the breathing, because due to the fibrosis in the lungs, and there is a effect. Every book of the is changed. Every chapter is amended in API's book after the COVID, because COVID has changed so many dimensions of the pathology. So we should be updated regarding this, because this is the most important topic, or entry of the patient, and this also make goodwill with the patient and rapport with the patient and their relatives. How we deal with the patient, that is also very important, because all this disease is directly related with the anxiety and daily apprehension of your daily working pattern. So we are here always advise the patient lifestyle modification, because lifestyle modification is very, very important in this disease pathology. Thanks a lot for cooperating, all the panelists and my chairpersons. Thank you so much.
Namaskar Singh sir and Dr.
Sir, namaskar,
Vaibhav. I just want some light on a few words, like few topics you can say, like uh, what you will say about that is impending MI.
Yes, sir. Impending MI.
What you will say about the impending MI?
Sir, impending MI is we are suspecting a patient which is not full-fledged, present their signs, symptoms, and ECG change or echo change, because sometimes patient occlusion of the coronary arteries is the plaque is maybe ruptured or under, or it is to be the, we can say, potential to rupture.
No,
But it's
sir,
not rupture.
I am asking about the approach of the patient for the doubtful diagnosis. For how long is some people say ECG every hour, some people say cardiac enzyme every 2 hours or 3 hours. How long we can keep a patient in a doubtful diagnosis, and is there any protocol for the ECG and frequency of the ECG and cardiac markers? If you
Sir,
and Dr. Vaibhav will want to say something.
Sir, we should at least observe the patient for 6 hours. Minimum, if there is a no significant, patient should be given opportunity for the observation for at least 6 hours, serial ECG and serial cardiac enzymes. Or if
So
you know
any
better, then
time
you can.
duration defined for the cardiac enzymes and the ECG frequency. Some people do it every hour. Some people doing it every 2 hours. Or is we can do it by ourselves. We have to decide this, because I used to do every 2 hours if nothing happens in between.
Sir, this is depend on the your setup. If there is a monitor facility is there, you can monitor the patient. So ECG can be monitored, and for documentation purpose, ECG should be taken hourly, because we are living in the era of consumer protection. So that is the most important, to save our skin also, not only treat the patient. So I advise you take the serial ECG hourly in such cases, because ECG is the documents since beginning to the end of the patient, or even the flat in the ICU or CCU, you have worked, we wait for that till the ECG become the flat. So ECG is the document, because even a layman say नहीं डॉक्टर साहब ने कुछ नहीं देखा था और वो हमें देख करके CPR शुरू कर दी थी. So everything should be labeled and documented. Whatever you are doing, and you should simultaneously explain the patient,
सर मान
attendant
लीजिए
and relatives.
ECG हम ECG उतना कन्विंसिंग नहीं है और हमको कार्डियक मार्कर भी नहीं मिल रहे, रेज नहीं मिल रहे किसी भी तरीके से, एब्सोल्युटली नॉर्मल है फॉर द 6 और 8 आवर्स तक भी. लोडिंग डोज के लिए क्या कहेंगे सर आप?
सर लोडिंग डोज एस्पिरिन तो आपको हर हालत में देना ही देना है सभी पेशेंटों को. क्लोपिडोग्रिल,
You are saying what we are practicing.
Yes. No, I don't agree to this, because what happens every day that every patient who comes to the ER just get a loading for no reason, even if the pain is non-cardiac, which is not true. So unless and until you have some changes, because this is everyday things that every patient, whatever, for every sort of thing, he is coming to the ER, loading is like a primary thing. So it's not necessary to give loading in each patient if it's not justified. Many patients just come with atypical pain. What's the need of giving a loading dose in that patients? So none of the guidelines say for giving a whether it's a ACC or ESC, any guidelines, they don't say to give loading in every damn patient which is coming to the ER for any sort of atypical chest pain. First, we have to differentiate between whether it's a typical or an atypical chest pain, because each has, we have to see the risk factors and complications as well. So I don't agree with the concept of giving loading in each and every patient till the time we have confirmed that yes, it's an ACS or a suspected CAD. Many times what happens, a patient is already taking his antiplatelets every day. He is on 2 blood thinners. Even then they're giving loading dose. What's the use of that? Loading means that patient has not been taking previously. So now we have to load it because that requires a particular threshold after which it can work. He's already on a maintenance dose. So, and if he's coming with a chest pain, what's the use of it? Or if it is a loading has to be given, it has to be given a different antiplatelet. Like if he may be taking aspirin plus clopidogrel, it may happen that he may still complain of chest pain after angioplasty, though he may be resistant to clopidogrel. Either we have to change it to prasugrel or ticagrelol in that case. Not that, yes, a loading has to be in every patient in that way.
Good morning, sir.
True, sir.
One small doubt. In your vast experience, loading dose giving clopidogrel 300 milligram or loading dose of ticagrelor 90/2, which has been more effective, sir?
So it all depends. So suppose there's a first we have to see the duration and onset of action. If you go by the literature, ticagrelor has onset of action in 2 hours, 30 minutes to 2 hours. But clopidogrel has onset of action in 2 to 6 hours. So ticagrelor works faster when we go for the onset of action.
Exactly.
So prasugrel works start functioning after every 2 to 6 hours. So in fact, now the IV candigrelol, which works within 3 to 5 minutes. So if we have the availability of candigrelol, so which comes by the name candigrelol, so if we suspecting a patient with acute MI, that could also begin as a loading dose and then maintenance dose till the time we go for the angioplasty.
Thank you very much.
Sir, Dr. Vaibhav, sir, what
Yeah.
you will say about this duration of frequency of ECG and frequency of cardiac marker and the stay of the patient in observation in a doubtful ACS?
So again, it all depends on the, suppose a patient comes to you with a history of chest pain for the last 6 hours. We already know that he has been having a chest pain for the last 6 hours. When the first set will give us a fair idea, because we know at what point in time our troponins and CKMB peak. So they peak around after 4 to 6 hours. So we know that, yes, it's already been 6 hours, so they would be peaking. So even the first set will give us a fair idea what to do in the next. But as a patient comes with a history of around 2 hours, maybe. So first you can get 1 cardiac enzyme scan immediately, and then maybe a total of 6 hours, that will be a good idea. 6 to 8 hours would be a good idea to repeat it. Not like every hour to save our skin. So if you're documenting it, yes, the patient came with complaint of chest pain for the last 2 hours. He started having pain at 10 a.m. and now he's at 12 a.m. Obviously, we know that, yes, it's been already been 2 hours. Now we have to repeat the sample at 4 hours. Doesn't make any sense to do it every 1 hour. If you have documented it well, so it doesn't make sense to waste resources for no reason to save our skin. Documentation is another important thing to save our skin.
Thank you very much, sir.
हेलो
Yeah.
मैं
Thank you, everyone.
हेलो सर, मैं डॉक्टर योगी सिंह बुलंदशहर से बोल रहा हूँ। मैं चेस्ट फिजिशियन हूँ सर। बहुत सारे केसेस में जो चेस्ट पेन की कंप्लेंट लेकर के आते हैं तो कार्डियोलॉजिस्ट केवल कार्डियोलॉजी के बारे में ही सोचते रहते हैं। तो ईसीजी कराइए, इको कराइए, लेकिन सर एक प्लेन चेस्ट एक्सरे भी इमीडिएटली कराइए।
Definitely.
मैंने बहुत सारे प्लूरल इफ्यूजन के केसेस, न्यूमोथोरेक्स के केसेस देखे हैं जो 1 हफ्ते कार्डियोलॉजिस्ट के ट्रीटमेंट के बाद मेरे पास आते हैं। तो बस इतना ही कहना था सर। धन्यवाद सर।
Very well, right. So that's what we were discussing, that history is more important to see what's the patient presentation. Is it cardiac or non-cardiac? I think Dr. Shashikant Mishra has also joined. So what's your thought on this, Dr. Mishra?
Shashi, you're mute.
Hi, good morning. I think the question that was raised by Dr. Saab is quite valid, that we should not be only looking from the cardiac point of view, but there is an exception to that. First thing first. So if you are having a chest pain, which is very typical of any cardiac problem, we should actually first rule out the cardiac problem. And once that thing is ruled out, then we go for pleural effusion or other causes of, definitely there are numerous causes of pleural effusion. So I feel we should not be ignoring anything. In fact, we have to treat as a whole, the whole patient. But definitely the cardiac thing has to be ruled out first. And at the simultaneously, other causes should also be explored and accordingly treated. So definitely pleural effusion, missing a pleural effusion by a cardiologist is not acceptable. So I would definitely say that Dr. Saab is right in that. But since cardiac problem being a emergency, I think that has to be tackled first. That's my point of view.
I guess that was a wonderful and healthy discussion. Hats off to Dr. KP Singh that he presented his thoughts without any PPT in this era of digitalization. So definitely that's worth appreciation. What I could get from all this discussion was that being a chest physician, cardiologist, we have to look for both cardiac and non-cardiac causes of chest pain, documentation of what we are doing, and whatever and the communication of the same is equally important. What we communicate should be documented, and what we document should be communicated. And at the same time, I understand that definitely patient is priority in all the situation, and we must not compromise at that particular point. When we talk of chest pain, definitely respiratory system is equally important. Sometimes even gallstone can present as chest pain. Sometimes gastritis can present as chest pain. Sometimes simple osteoporosis leading on to chest pain is not uncommon. Very common, it's seen that just hypovitaminosis D is also presenting as a chest pain. So we need to have a great sense of clinical acumen when we are talking of any particular disease. Today, we are restricting ourselves to cardiology, but in general, we need to be physician first and specialist later, probably. Definitely, if we go by WHO guidelines, they suggest that there is criteria for diagnosing coronary artery disease, which could be on symptoms, which could be on ECG, enzymes, and echo findings. And they suggest if any of the three is there, definitely it should be thought of cardiac involvement. Maybe ECG changes, maybe symptoms, maybe echo, maybe enzymes. Unfortunately, none of these are perfect. They all have their limitations. Invariably, it has also been observed that at times the presentations are late. Sometimes the ECG findings come after some time the patient has presented, that we were talking about the impending cardiac involvement. So all these things do happen. So at times we give benefit of doubt, thinking that कि अगर cardiac होगा तो क्या फर्क पड़ जाएगा अगर 300 मिलीग्राम एस्पिरिन और 300 क्लोपिडोग्रेल विद 40 स्टैटिन खिला ही दिया तो नुकसान तो कम से कम नहीं होगा, ये भी कभी कभी दिमाग में आता है. Maybe it is not cardiac, maybe it was just a dose of pantoprazole which was required, but somehow this comes to mind. So we have to look forward to the risk factors, as probably the Madhav Bansal and Dr. Pragnesh suggested, that maybe risk profiling can be helpful in such situations. Coming to UV sir, जैसा सर ने बताया कि कभी कभी ये रेस्पिरेटरी कॉज होता है जो कि एक्सरे पर हम लोग पिकअप कर सकते हैं, लेकिन इट्स अदर वे अराउंड ऑल्सो. इट्स वेरी not uncommon to see that dyspneic patients are being treated with inhalers and the cause was probably just an uncontrolled hypertension. Maybe that treatment of hypertension can solve that problem of dyspnea. ऐसा भी देखा गया है कि patients are on antihypertensives, they are well controlled, but probably they were not on diuretics, and just adding a thiazide or loop diuretic depending on the situation, if the patient is an LVF, maybe loop diuretic, or just an addition of diuretic, especially if the patient is on amlodipine, which helps to reduce the preload, can equally be helpful. So I must insist and restating that a total and holistic approach is probably the key to the success and betterment of the patient. Any thoughts on that? I was just trying to put all the things together in one place. Maybe I have overlapped, maybe some of us are not agreeing with what I'm saying. So kindly comment on, and maybe we'll have some more views. Nishant is also listening here. Vaibhav, you are here. I'm really, this is first interaction with you, Dr. Vaibhav, but it was a wonderful interaction.
Thank
You have shown a different perspective to our meetings, which we have not seen previously on board. Definitely, you are an add-on to presentations in IACC. I must appreciate that.
Thank you so much. No, I completely agree with you. There was a patient recently, he came with complaint of chest pain, but actually it was a cholelithiasis. So he was being planned for surgery, but as in the ER customary that every patient with chest pain get a loading dose. That was the reason, and he was planned for surgery. So his surgery was delayed because we have given a loading for him.
Exactly.
So we have to first rule out that yes, there are no other causes for. I agree that cardiac comes first, but not at the cost of other things.
Exactly.
So history becomes more important, and examination, which we are lacking these days. We hardly use our stethoscope instead of just using the echo machine because it's handy. So that gives us a fair idea that what sort of complaints does he have, whether he have any crepes, whether he is in failure or not, whether he have any added sound or anything, even the clinical examination. So that gives a fair idea that what should we do next. You know what happens these days, any patient coming to your OPD for any sort of chest pain, he directly goes to the cath lab without any history. So it happens many a times. We are not going by the guidelines or anything like that. It's just what our senior says that yes, yaar, mere senior ne to ye kaha tha, mere usne to ye, what we have learned from our seniors, that's it. But it's a time of evidence-based, not an eminence-based. So if you have any evidence of that, yes, he have a chest pain, all the criteria of history, and then examination, and then your clinical exam results, then obviously he requires a cath. So not in every patient. If you see the data in the last couple of, this was published lately, that yes, out of 100, I'm just giving an example, almost like 30% caths are normal NGOs. So because they have not been taken very well, a patient can walk for almost like 10 miles on TMTs. TMT is positive, but just for that, TMTs mild changes. Even in the young guys, young females, we are giving this a positive. Doesn't make any sense. So I think it's a good, healthy discussion, and we can go to the next. Obviously, due to the sanctity of time, we can go to the next presentation, and obviously we can take it from there.
Thank you, Dr. Vaibhav, for elaborating for false angio, or we can say there we are even so many meta-analysis study is 2010. 40% stent was wrongly.
That's a completely different topic. That's a you know all the not to say on record. That's a completely different topic. If that thing happens, then obviously you know the things where we are going.
Fortunately, we all are clinical
Dr. Jagnany,
cardiologists
I
here,
met
so we
with
can
Dr.
say this.
Vaibhav
Otherwise,
recently.
that's a different thing. We may not be able to talk about that.
Dr. Jagnany,
Uh,
we recently
just
met with
this.
Dr. Vaibhav in Fortis, Gurgaon. He's very marvelous
Okay.
person. And कभी कभी तो DM को भी इनसे
Yeah, lucky
complex
to have
होता
him
रहता
here.
है sir. lot of senior
Just want to
DMs.
share one case here. This is a very closely related case to me, a very close relative to me. And the patient was around about 60, 65 years old lady. She presented with chest discomfort. ECG was normal, echo normal. First time she was diagnosed to have blood pressure. Patient was started on antihypertensives. 4 antihypertensives were used sequentially over a period of 1 week, including amlodipine, telmisartan, nebivolol, and torezamide. Unfortunately, despite using meticulously sufficient amount of these 4 drugs, we could not achieve a blood pressure of less than 130/80. It remained round about 150/90. Chest discomfort also remained there despite adding aspirin and statins. No finding on ECG, angines, or echo. We were uncomfortable. Patient is relative to me, very closely related to me. We went for an angio. I went to Bombay with my teacher, Dr. A.C. Pereira, who was the first person to teach cardiology in my life. We went there. He was also very apprehensive in doing, but we insisted कि सर अब रांची से बॉम्बे तक आए हैं तो आप एनजीओ कर ही दीजिए. As expected, NGO was also normal. Then I asked him, sir, how to explain this? He said कि we are doing coronary NGO. We are seeing only epicardial coronaries. We are not seeing endocardial coronaries. What he did was he just added nicorandil. Slowly, the antihypertensives were reduced and the patient became asymptomatic. Presently, she is on statin low dose, nebivolol low dose. Diuretic is just hydrochlorothiazide. Half dose of telmisartan 40 milligram, 5 milligram amlodipine, and patient is asymptomatic. So what I want to establish here is, despite having normal findings, sometimes situations like this may come where endocardium is involved and probably molecules like nicorandil can be helpful. So symptoms are also important. We need to be very much enthusiastic, very much clinical acumen is required, and probably the gray hairs helped us to diagnose correctly, and we could reach this situation of asymptomatology. Thank you so much. We are moving to next slide. Before we go, I would like to present a token of appreciation for our chairpersons and speakers. Dr. K.P. Singh, memento and certificate, Dr. Munir, Dr. Sudipta, Dr. A.K. Jagnany sir, and Dr. Tan Patel. With this, there's little bit changes in scheduled presentation. Our next presentation is with Dr. Nishant. Dr. Nishant is a clinical cardiologist. He is my colleague. We did our clinical cardiology PGDCC together at Ranchi. He is also master in preventive and social medicine and presenting working with Tata Cancer Hospital, Muzaffarpur, in the Department of Preventive Cardiology. He has been faculty to our association as well as other places. Dr. Rupam Sharma, Dr. Santosh Gupta, Dr. Prem Prakash, and Dr. Hirak Jyoti from Jaipur, Jamshedpur, and Kolkata are chairpersons. He will be talking on role of palliative care in cardiology. So with this, I hand over the session to Dr. Nishant for his presentation.
Thank you very much, sir. Can I share my screen, sir? Thank you. 1 minute.
Sure.
I think my screen is visible, sir. Am I audible?
Yes, sir. It is visible and you are audible, sir.
Dr. Vinny, thank you very much for a warm introduction. So I'll begin my class on the topic on role of palliative care in cardiology. Now, palliative care, it's a norm in oncology where we practice palliative care day in and day out in oncology. But I was recently going through the national guideline for palliative care, which has been released by Government of India, and I'll share it with all of you in the forum after the talk is over, and you all can go through it. It's a very wonderful document. It talks about what palliative care is and how it was important. One of the important things that came to my notice on the very first pages of the slide was this particular graph. Now, this particular graph shows the need for palliative care across all different kinds of diseases. And what I saw was a majority of patients with cardiovascular disease require palliative care. And I remember doing our cardiology training and working in tertiary care institutes, we never heard of palliative care. Though we knew its importance, we did not know the term. We did that something similar to it, but we never understood what we were doing. We knew what was important, but we never put it scientifically in words. And it has been already happening in oncology for a quite long time, because oncology is a branch where people have a certain time when the disease is diagnosed. There is a certain time when we know how the disease will progress. In cardiology, however, after a certain time, there is some ambiguity there. So we do not know. And the episode is quite sudden. So it takes it sort of, it's like a shock to the whole family. It's like a road traffic accident to the whole family. So it's a different thing, entity altogether. And I've seen nobody in our setting talking about palliative care in cardiology patient. And there's a certain subsection of patients who definitely need palliative care. So in my present talk, I'll just lay out the principle of palliative care, just to inform what is palliative care and how to go about it. All right. So we know about disease management, and we do about, whenever we have a disease, we do the disease management, we control the pathophysiological symptoms. If a patient has chest pain, he has coronary disease, we ensure that the disease pathology is controlled. We prescribe him statin, we prescribe him antiplatelets, so the disease pathology per se doesn't progress. Our also secondary goal is to manage symptoms. If we cannot manage symptom and we just manage disease, then the treatment is not complete. The patient will always say कि sir कुछ तो कर लो, पर मेरा बीमारी तो है मुझे. I still have the symptoms. I still have chest pain. I still work. I get chest pain. Dr. Vinny said a similar example that it is important to also manage disease and also control symptoms. You do not do all those things, the patient may not have good relief altogether. The third domain, what we forget all the time, is psychosocial care. The reason we forget, because we know it's something very big. And we never bother to ask our patient, do you really need this treatment? Do you really want this treatment? There's a good article when all our colleagues were quoting about the number of angiographies we've done. But have we ever asked an 85-year-old gentleman, do you want an angiography done? I don't think we have asked anybody. Or have we asked them to make an informed decision? Do you really want to undergo a bypass surgery at the age of 90 years of age? He may say, no, I do not want to, I just want to die peacefully in my bed. But we never give that decision to our patient. We ensure that decision is taken by his patient relative, and the patient is kind of taken as surrogate, is kept aside, and is never involved in the decision. The patient attendant never involves the patient. They want to cure themselves from the social need. Everybody is, I'm taking care of my grandfather or father in a very manner which is appropriate, but we never ask the patient what does he want truly, and the patient is never able to make that important decision of his life, and which is very important. So what is palliative care? In short, this is a very important slide. What is it? affirms life and regards dying as a normal process. Death is natural and death is normal. That we got to realize. As physicians, as cardiologists and everything, we feel when a patient dies, it's our failure. No, it's not our failure. Death is natural, it's normal, it is bound to occur. There are two events in somebody's life that is bound to occur. One is birth and one is death. And unfortunately, we do not have any control on the either. We don't know when a child will be born. We may know the exact gestation age, but we may not know, even if the labor pain has started, what is the time and what is the place and how the child will be born. And we do not know what time we'll die. No matter how serious illnesses we have, a good healthy person may die on an instant, and a very sickly person may live for years and decades on and surprise all the physicians around him. So we believe in palliative care. We affirm life. We need to affirm life and understand that death is a natural process. What it does not mean is we hasten or we postpone death. That means we do not give any drugs which can increase the death or do any intervention which can postpone death. We cannot do that. Then our goal here is to provide symptom relief. There are many times, like example in chronic heart failure or in patients with primary pulmonary hypertension, where we know we cannot treat the disease, or in congenital heart diseases where patients have severe pulmonary artery hypertension, where we cannot treat the patient. We cannot do an heart lung bypass, and we do not know the whole pathology. We cannot control it. There we can provide symptom relief just as a last resort, and it is not a last resort. It is the symptom relief that matches. Idea is to do low tech things in a very high way. For example, we always try to initiate bladder. If somebody is not passing maturation, we just look for it. We never think there are non-pharmacological methods to initiate maturation. If a patient is become breathless, our first response is Nasix Dedo will be all right. We never think of non-pharmacological ways or non-invasive ways of handling breathlessness. We don't think of that. We don't think of low-tech methods which have high impact and perhaps are much more helpful than putting somebody in the ICU and putting him on a ventilator and putting this thing. It is not the last resort. It integrates psychosocial, emotional, and spiritual care. Now, it is very important when a person has a disease, the first question he asks to the doctor, "Mujhe kyun hua?" Why did I have this disease? And unfortunately, neither the doctor nor the patient, the doctor doesn't have the answer because he's not prepared to answer those questions. He's not trained. His medical training has not trained him to be beyond the realm of objectivity. He cannot be subjective. He may say something based on his belief if the patient is very close to him, but he will not dwell a lot into it, because he feels if he dwells a lot into it, there's a large list of patients which is waiting behind in his room, and if he starts talking to everybody about spirituality, his whole day will go out talking about spirituality. Okay, so he never integrates his psychosocial, emotional, and spiritual connect. That is very important in providing a care. It does not mean shutting down the patient. मेरे पास मत आओ, बीमारी मुझे मालूम हो गया, दवा ये है, दवा खाओ, खुश रहो. That is what I can do. I cannot change the disease. And we just counsel the patient. We don't talk to the patient. We don't talk to the patient person. We talk to the attendant. We support the caregiver. There is a person who comes with this patient. That is his caregiver, his primary caregiver. His primary caregiver is perhaps much more ill than the person who is sitting on the wheelchair. We do not understand the pain this caregiver is going through. We do not give him a respite, and we do not ensure that his responsibility, what work he is doing, it's commendable. We do not acknowledge that. Palliative care is not static. It is very dynamic. It's a very dynamic branch. And here we think about long-term trajectories. It is not synonymous with terminal care. It doesn't mean the patient is about to die and we are giving palliative care. Just ऐसा नहीं कि patient मरने वाला ही है, तो चलो palliative में भेज देते हैं, palliative care करते हैं. That is not palliative care. So I hope I have made some understanding. I may not be able to completely make you understand in just one slide, but as I go further in my slides, I hope you'll have some idea. Later, when I share the book, you'll all go through it. So when we talk about disease, we talk only about this green substance. Our clinical training trains us only about this disease focused care. If a person has chest pain, we only look about cardiology. The gastroenterologist will look only at the abdomen. The orthopedician will look only after the RIC page, and our focus is there. If we find a disease, if we have a set of 5 symptoms, and if that symptoms matches our patient, we'll do the diagnosis according to it, and we'll provide care according to it. Anything beyond or anything within the realm, we will not touch. Here in palliative care, the word palliative comes from the Greek word pallium. Pallium means a cloak. It's like a chadar. It's like bacha, choda bacha hoता है, when he feels scared, he pulls this cloak over his head and the whole world is lost. So this is what pallium means. Pallium means providing a cloak. So the physician the physician alone cannot ensure this. So he has a group of people with him. They are medical social workers, they are trained nurses, they are spiritual physiotherapists, they are people who look after psychological domain. And this group of people ensure all these domains are addressed. His disease focused care, which is rolled by the physician, he also provides comfort, and psychosocial and spiritual support is also provided. Then we know there is death. The patient, once he dies, the family needs to grieve for a certain amount of time. That time is around 13 days, what we say in normal Hindu literature. And in different faiths, they have different timings. So suppose we assume they grieve for 13 and 14 days, but that is the natural time of grief. We do not want to intervene or not touch them. Once that period is over, and if the grief persists, that is called an unnatural grief. One unnatural grief that has happened. Suppose there is a loss of child, and the mother and the father will grieve for a longer time. The woman who has lost a husband or a husband who has lost his wife, they grieve for a longer duration of time. These patients are again followed up and they are again provided services. This is called bereavement services. And these services ensure that is follow-up time, they go back to their normal mechanism or they go back to their normal activity and they are normally bereaved. This is called the bereavement period. So this is what palliative care implies. It is basically an entire spiritual concept, entire concept of handling a disease which is of terminal illness and a disease which is of non-communicable in nature, mostly all the cardiovascular disease, all the cerebrovascular diseases, all the strokes, all the cancers, Alzheimer's, dementia, everything. And in fact, elderly age, old age, all the diseases that we see today, which we are facing in our time, we all in later duration of time need palliative care. Because if we do not understand palliative care, we'll all end up dying on beds of our ICUs with a ventilator in our mouth and a Ryle's tube and a Foley's catheter in our through our urethra. So that would be the death to all of us. But if we understand the need for palliative care, we can ensure that there's death in dignity. There is dignity in death, and we ensure that patients have better comfort. So this is what normal thing begins. There is a diagnosis of disease. Now this disease is supposed to be, suppose it's a cancer or it's a chronic heart failure, or the person has a large myocardial infarction and he has a triple artery bypass. And we know relatively his heart function has declined, and over a period of time, he will require repeated admission and he'll need to come to us. Or the patient has been diagnosed by pulmonary hypertension or diagnosed with certain diseases, which we know will have gradual decline over a period of time. And he may not be able to become normal over a period of time. So these patients, at the moment the diagnosis begins, we counsel them. The counseling is about what? It's about why the disease occurs, understanding his whole psychosocial symptom, addressing his spiritual needs. He will first question will be, सर मुझे क्यों हुआ? मैं शुगर खाता हूँ, मैं salt नहीं खाता हूँ, मैं non-veg नहीं खाता, I'm non-alcoholic, I'm everything, and suddenly I have a triple artery disease. Why do I have the disease? Why do I need to undergo bypass? What will happen to my children? What will happen to my family members? Why I need to have this? The moment the diagnosis is made, the physician and the palliative care ensures these needs of the patient, the spiritual domain, the psychological domain, are addressed. And as the curative domain fades away, the palliative care domain increases. Then comes the time of hospice. Hospice is a place where the patient has understood completely that he's about to die. And he's about to die and not die today. He may die in some duration of time. So he makes an advanced decision. This is called an advanced medical directive. And this is what has been legalized by the Supreme Court of India, where a patient on his own will, on his own fruition, can decide, make a decision what he wants to happen to him when he is at a terminal stage of his illness. Because unfortunately, still for us, if a patient is intubated and brain dead, in order to extubate him or do not resuscitate, there's a large judicial process. The process there has to be a medical committee has to be constituted, and this medical committee will inform the subjudicial magistrate. The subjudicial magistrate will again then come to place, and then finally the patient can be extubated. But if the patient who is seriously ill, they understand in certain 5 years or 10 years of time, and they can change this directive, or 5 years of time, I am going to become very sick, and I may end up requiring something which I may not want. So we ask the patient, do you really want this thing to happen to you? So he'll convey to us, no, I don't want tubes in my mouth. I want to lie sleepy, painless on my bed in my house. If he conveys this, then that is called the advanced medical directive, that he has to get it written down, and he can change this directive anytime. He can make people who can take decision for him when he is unable to make the decision. This is very helpful in patients, those who have chronic heart failures, patients, those who have primary pulmonary hypertensions, those who have Alzheimer's, those who have Parkinsonism, those who have multiple cerebrovascular diseases. All those patients can, when there's a time in their life when they are capable enough to make the decision, they can make the decision. They can choose to be in a hospice care where they will be not given any IV antibiotics. They'll just be given subcutaneous injection if they want it then, and they would be allowed to die peacefully. And once that has occurred, there's a period of bereavement for the family members that occurs. So this is the entire trajectory of palliative care. So it includes because the doctor alone cannot do it. It requires counselors, it requires social workers, it requires caregivers, it requires doctors, it requires volunteers. These volunteers are unpaid volunteers. In India, Kerala has the best palliative care model. If you read about the palliative care concept, and some of my colleagues from Kerala will know this, they have one of the best volunteers are there. Every particular community have a group of volunteers who ensures the patient who is in terminal ill can go to watch movies, can go to watch football, or there's also instances where a terminally ill mother wanted to see their child get married, and in the ICU, the palliative care physician arranged the marriage to take place in front of her eyes. So she was comfortable and she died in peace. So there are three terminologies which we always talk about. There's called the illness, there's something called the disease, and there's something called the sickness. Though we use it interchangeably, it is quite different. Illness is a subjective feel. I may feel ill. I may talk to my work provider and tell that I am ill, I cannot come to the work. So ill is a subjective experience. It is a group of symptoms that may precipitate of me not feeling well. I may not have an underlying pathology of the disease, but I may just simply, I'm not feeling well today, I'm feeling ill today. So that is called illness. Disease is an underlying pathology which causes the disease per se. Now, disease may not lead to illness. There are many people who have diabetes, but they routinely do their work. Many people who have their hypertension, they routinely do their work. So disease may not per se lead to illness, and illness may be present in absence of disease, and that is very important to understand. And third is the sickness. Sickness comes when we are unable to meet our social cultural beliefs, when we are unable to fulfill our social responsibility. That is why we have the concept of sick leave. We do not have ill leave, we don't have disease leave. When because of disease or because of illness, we are unable to fulfill our social responsibility. Suppose my social responsibility as a doctor is to see my patients or attend a function, but because of any disease or illness, I am unable to do that, then I am considered as sick. So it is very important to differentiate these three terms, because this is very important, because we have to always ask the person, are you ill? We know of the disease, and we also have to find about sickness. And it is the sickness that we have to cure. It's not the disease or the illness. Disease and illness we can control with medicine, because illness we really cannot do many things, and we have to talk to patient about it and ask about subjective appearance. It is very subjective. But sickness is the social cultural concept which the person has towards the disease and what impacts the disease. Hello, am I audible yet? Hello.
Yes.
Yeah. So when we talk about a disease, now what happens with any disease? Now see, whenever there is an acute disease, the person suddenly has declined. Suppose patient has an acute myocardial infarction. There's a sudden decline in function, and suddenly he improves and he goes back to his normal lifestyle. Now, this actually happens in acute myocardial infarction. Patient comes with acute onset chest pain. We suddenly thrombolize him or take him to a cath lab, put a stent, and suddenly over a gradual period of time, he recovers from this illness and becomes normal. And this person may not require palliative care, may just require palliative care in the initial part of the disease where he is taken care of. But suddenly comes a patient who has a multivalvular disease, who has a low ejection fraction, and we don't know where to should take him for surgery or not take him for surgery. The surgery is quite risky, and the patient is not really willing, and the patient doesn't want to go. Or even if we take him for surgery, we know over a period of time his disease will gradually worsen. He will fall through the ladder. There will be episodes where he'll recover and again come back. And this may happen not over years, this may happen over decades. So this decadal fall over the period here, and through that decade, the patient may need palliative care. And here the role of palliative care is very important because we have to ensure that not every serious exacerbation leads to an admission. Every serious admission can be managed very simply, and we manage very this thing. And every time the patient is made aware what he is suffering from. A large number of times the patient is never aware what he is suffering from, and the family keeps it with himself. कि नहीं आपको पता जाना, आप अपना आराम से रहिए, आपको अस्पताल जाना है. And the moment they realize कि I have shortness of breath and I become again short of breath, and again now I have to go to the hospital, his breathlessness suddenly increases. So we never, because the patient has never understood what disease he's suffering from. And this is very common in our ICUs. Moment the patient enters the ICU, he's very breathless. Suddenly we give him a small amount of Lasix, either it becomes all right, and within the next 24 hours, he want to go out. I want to go out. I don't want to stay here. I don't want to stay here. There is this chronic trajectory where the patient doesn't want to stay in the hospital. So a chronic illness like cardiovascular disease, Alzheimer's, dementia, is like a water of hand. If you keep a bowl of water in your hand and keep your hand straight, after a period of time, that becomes a certain headache on your hand. It becomes a certain headache on your arm. You cannot lift that water. A chronic disease is something like that. It is that constant burden on your head. The person lives, breathes, and thinks about it throughout the day. It's every activity in his life is guided by this particular disease which is holding. If he's labeled that you have a cardiac illness, you have a heart disease, he will always tell you, no matter what the disease is, he's supposed to go for work. I have heart disease, I cannot do this. I have heart disease, I cannot do this. I have heart disease, I cannot do this. Or somebody, his relative will tell you, because of his heart disease, I cannot feed him this. I cannot let him have this. Let him have this. So for every activity, that particular disease will become one entity to obstruct his illness. And that becomes very disturbing for the patient per se. And in order to tackle that, the palliative care physician plays a very important role. Now, the whole idea of palliative care began with this lady. Now, even this concept is very old in India. People have already been dying to Kashis. In Ashoka, in the times of modern times, there were certain places on the band of Ganges where people used to go and die. So, in India, the concept of palliative care is very easily understood because the Eastern psychology understands that the life is multifaceted, and with the time to leave the life, we just want to die in peace, because that is very well understood in Indian psychology. But over the period of time, after the advent of antibiotic and multiple interventions, we have suddenly forgotten about palliative care. We don't talk about it, even though we know the patient also doesn't talk about it because he thinks he can cure everything. We can cure everything, and unfortunately we cannot cure everything, and we think that we can beat death all the time. Every time the doctor feels that we have beaten a pulmonary edema, we are very, very happy. Okay, we have beaten a pulmonary edema, without realizing the fact that this event is going to occur again after 3 months. एंड वी सोच अब देखा जाएगा ना, अभी क्यों सोचते हैं उसके बारे में, अभी तो ठीक हो गया ना, अभी तो घर जा रहा है ना, अभी तो इज ऑल राइट. बट वी नेवर डिस्कस दैट फ्यूचर इवेंट विद द पेशेंट. So this concept of palliative care started in a very objective term by this lady called the Dame Cicely Saunders. And if you want to know about her, you can read about her in the Wikipedia. And she's a very interesting lady because she came out with this concept. Why do people, there's a very concept she came about, how people die remains in memory of those who live on. And she understood, seeing that people before dying have certain wishes and regards, and those are not met. And a large number of people today are dying in agony. The poor die without any care and they die in agony. The rich also die in agony because they're there in ICUs, they die in isolation, they don't die with their family support, they die in agony. So both the rich and the poor die in agony. So DC started with the concept of palliative care, and it was first started in London. She was actually a social worker first, then she trained, became a nurse, and later she trained and became a doctor. And then she advocated for the role of palliative care. And in WHO, then termed the palliative care is the best fight for cancer. And later, palliative care has been started across the world. WHO acknowledges the role of palliative care in all the chronic illnesses. Recently, the Supreme Court judgment, which has asked about all the states of the India to talk about the role of palliative care and how informed the physicians, the doctors, and the patients at large are about palliative care. I'm very sure none of our physician colleagues would have even heard the term of palliative care. And I think we can have a vote after this time, after this conference is over, that none of us would have heard of, many of us would have worked in ICUs for a long duration of time in a tertiary corporate hospital, but we would have never discussed the term what is palliative care. So by 60s, in the year 1960s, the evolution started, and by 2020, till that COVID time, it has become now a routine practice. At least in cancer, it is a routine practice. We are advocating for, we are training palliative care physicians across different parts of Bihar for identifying other non-communicable diseases like cardiovascular diseases, cerebrovascular diseases, Alzheimer's, dementias, old age per se. So all these people with all these progressive illnesses, and all people who are going to become old after 50, we all going to become old. We all going to need palliative care because we all have certain demands which cannot be addressed by one single physician. That one single physician cannot address everything. He may teach my blood pressure, he may control my diabetes, but he cannot answer my spiritual crisis. But at least the patient, the doctor must understand if this person has a spiritual crisis, and if he understands if the person has a spiritual crisis, where to refer it to him, who is the person who can objectively talk to him, or if the person has a very serious illness, how do I communicate to his family? How do I understand what's the ethical principle here? Should I communicate about a serious illness to the patient or not to the patient? Or should the patient has a right to know about the disease, or should we understand with the patient attendant, no, don't tell it to my mother, the mother will feel bad about it and she'll die suddenly. That is called collusion. Should we promote collusion or should we avoid collusion? So there are many things that we do not know. So palliative care in India started in TMC because it's a cancer hospital in 1980, where for pain they used to provide aspirin and opium tablets. And oral morphine is a very important concept in palliative care for pain control, which we will not talk about this talk, we'll talk about it later. And later in 1986, Santi Avedana Center in Mumbai was started with the first palliative care center. It was started in Mumbai. After that, you have the Sevagram Trust in palliative care. It is a role model for many palliative care. And today in India, palliative care is one of the best established at the community level in Kerala. I think many of my colleagues from Kerala would know about it. So palliative care is a very big thing in Kerala, and we need to also encourage all other different parts of the country and states to know about what palliative care is. So there is certain principles of bioethics, and there are 4 principles actually. I'll try to make it very simple, not make it very boring. The principle means autonomy, beneficence, non-maleficence, justice, and dignity. So what does autonomy means? Autonomy means a person has a right to decide for himself, but this decision should be made on informed decision. Suppose a patient, now it is very difficult to make it understand a person who doesn't know anything of a disease. Now suppose there's a person who understands the disease. Suppose there's a person who has, there are 2 ways do we handle problem. We tell, suppose a patient comes to us with a triple cardiovascular disease, we tell, okay, you need this bypass surgery, you don't need anything else, you need a stent implantation. Now this view is called a paternalistic view, where the doctor becomes a parent and gives the and treatment per se in his hand. Okay, this is what and this is what you need. This is called a very paternalistic attitude. The second method is called the cafeteria, where the doctor doesn't do anything. He provides a spectrum of things in front of the patient. You can do this, you can do this, you can do this. And the patient has virtually no idea what to pick because he is not trained. He doesn't know what to make the best decision. But autonomy means the patient is informed about the disease. He is made to understand in his own language. Now, this is very difficult in our scenario because a large number of people come from various learning education. Now, every person has some amount of intellect. It is the role of the physician to ensure the person understands what disease he is going through, or what disease does he have, and what is the progression of the disease. Whether this particular treatment will lead to cure, how costly it will be, and how effective it will be. And if he doesn't understand, get this care, what are the other options? So if he understands all these options very clearly, and then he takes an informed decision, Dr. Saab, I want to get this done, I don't want to get this done. The person takes the decision. That is called autonomy. Beneficence means that we as a person will do for the benefit of the patient. We shall not do something which harms the patient. We shall do everything in the benefit of the patient. Whatever benefits the patient most, we'll do it. Non-maleficence will, we will not do any harm to the patient. No matter what, we may want to put a stent, just see Liam, you don't want to put a stent. It may be doing harm. We do not want to do unnecessary surgery. We do not want to do unnecessary procedure or those fancy procedure like doing an cancer surgery in a person who is already 90-year-old. Doesn't make any sense. We can just ensure that patient has a normal living life. Ask him, does he want to really get it done? If he says, no, I don't want to get it done, then let him be. Justice means we will be right. We will be ensure that everybody gets the equal amount of care. It's not that the person who are well informed, very close to us, get very good care, and patient those who don't know, we just give them what care we want. And everybody has a right to dignity. Dignity is one of the very important concepts of bioethics. Now, I'll try to explain this to a small situation. There's a 34 gentleman who had benign cancer of the esophagus, or a cancer of the esophagus, and this we knew this cancer was going to reoccur, and he underwent radiotherapy and he still had dysphagia. And suddenly this gentleman reads about this particular expensive stents, which he read about in a piece paper. This is very common. A large number of people in our scenario who read about multiple therapies in newspaper and find about it and let come to the doctor. Is it important to us? Now, how can we make? Now, the autonomy here means you ensure the patient understands the disease he's having. You must tell him that this is the disease you're going to have and this is how the disease will progress. You must tell the patient about the benefit of the stenting. Does the stenting really helps? Does it help or not help? And is it this particular procedure will do more harm than any benefit? And finally, is the allocation of resources all right? And if the patient can truly afford this treatment for a family. So these will slowly answer the ethical principles of the principles. So we follow this 4-quadrant approach, and this talks about any treatment intervention. We talk about informed anatomy, autonomy. Then we talk about maleficence and justice, and if there are any legal and logistic policies. One of the important assets of palliative care is listening. Now, true listening is a love in action. That is what has been already said. I hope I'm audible. Hello?
Yes, sir, you are. Sir.
Yeah. So one of the important aspects of palliative care is listening. And this is what truly occurs in our ICUs. The doctor is very busy and is surrounded by so many people around him. And there's always, he doesn't have really time to talk to the patient. And there's a lot of missing in the communication skill. And it is very important in palliative care. We listen to our patient, what the patient is saying, rather than we say to patient what we want to say. So one of the few examples, there are very methods for communication skill. I'll not go into detail of that, but few principles. Always ask open-ended question. Like example, how are you feeling? How was your day like? What do you want to know about the disease? The patient says, I'm not feeling well. Tell me what you understand by not feeling well. You have to ask more open-ended question rather than asking close-ended. तबीयत तो ठीक है ना आपका? You are all right. I hope you're all right. These are all close-ended questions. So do not, I know it's a very practical thing. We always practice it, but in order to change this habit, we have to ask open-ended questions. Second, we should not give false hopes and reassurances. We should not tell that this procedure will completely cure your disease if you do not know about it. We must try to be very balanced in our approach. You must tell them what is the truth. You must tell them this is the disease and this is the outcome. We hope to do this and we want to achieve these things. So that is very important. We must respect the patient confidentiality and avoid unhealthy curiosity. And this is very important because many a times patient may feel distressed about multiple things and they may cause multiple traumatic. But the whole concept of communication, there is a method how to be talk, how do we look at the patient, how do we do non-verbal communications. There's a whole plethora of chapter about it. I will not discuss it here because it's a large, big topic about it. If you all want, I'll share the module for the palliative care online, and we all can go through it. With this, I'd like to end my presentation, and I'm open to any questions anybody has. I think my screen is stuck. Let me log in.
Yes, sir. It seems like the network bandwidth is slow,
Yeah,
sir.
I think it will be all right now. Correct. Yeah.
But that was a wonderful presentation, Dr. Kumar.
Thank you very much. Thank you very much.
So it's still a lot of time to go for hospice in India. I have worked
Yes.
myself in hospice and have been volunteer for a couple of patients, going with them to the movie, going with them to the market. So it's a completely different thing. So palliative care is still very underutilized, or you can say underused, especially in India. And one of the thing I
True.
feel, one of the reason is about our society and culture. So
Yes.
we as Indians are living as a joint family, but gradually that's been going
Yeah.
more towards nuclear family. So this
True.
more role towards in a nuclear families where you don't have anyone to take care. So hospice is much important in those scenario. Here, your parents
Yeah.
are staying with you, someone is there to take care for you. And in hospice, kids are not there with you, so someone else is taking care. So there comes the more role important of hospice. But I completely agree with you. Palliative care starts a day as we are diagnosed with some sort of a critical disease, because they go both hands in hand.
True.
And it's not just palliative care for the patient, it's also for the family. Those
Very true.
who want to understand or want to learn more about it, that what happened to their family member, why is they having that sort of disease and they're in grief, that sort of thing. So, that's more important. And it was really wonderful to see your thoughts in a very well elaborated way, that yes, how these things can be. I'm yet to learn more about the Kerala model. So yes, I'm pretty sure that would be good.
Uh, I'll update few things. First things, when you talk about hospice can be delivered not only at a particular place, it can be also delivered at home.
Of course.
We also have, like for cancer patients, we have home-based palliative care,
Yeah.
where our team go to the home and talk to the patient and take care of them. And if you want to know about the palliative care of the Kerala model, there is a global fellowship on palliative care, which is run by Pallium India. If you want, I'll share the brochure for it. I'm taking the training for it for right now. It's a 1-year fellowship. It's a WHO accredited fellowship, and I think most of our family physicians, colleagues, can go through it. It's a very beautiful course. It talks about communication, how a communication should be done, how we should communicate to the patient, how should we communicate to doctor, how should we break the bad news, how should we ask about advanced medical directive, what is the role of morphine, what are non-pharmacological method of controlling of breathlessness, what are nausea, vomiting, and everything. I talk about a entire holistic, how to answer spiritual domain questions, and it's very important in palliative care. So I think the whole module is there, whole this thing is there, and also entails 1 year, 1 month training in Kerala and Trivandrum. I think if you want, I'll share that brochure for palliative care training. I think the call is still open. I think many of us can join. I had finished the theoretical part. I am about to go for training. I'll go for training in next month or something like that. That's a very good thing to go at. Some palliative care is something we must undergo. Yeah.
So I have a couple of my patients who are under hospice care at home.
Yeah.
So in Fortis Gurgaon, we do have a palliative
Yes,
specialist.
correct,
So
yeah.
she takes care of all the departments.
Max does it. Max does it. Max also has Cipla. It's a Cipla model. Yeah.
Yeah,
Cipla
not just
CanCure does it. Correct.
it's
Yeah.
all departments.
Yeah,
So
correct.
in collaboration with that, we have a couple of our patients who are doing it good at home. So they have made sort of a makeshift ICUs at home. So one of the nurses who goes and takes care of these patients,
Yes.
and probably if required, they can give morphine. They have a
Correct,
nicotine
correct,
patch, sort of a patch. So
Fentanyl patch. Correct. Yeah.
fentanyl patch, sorry. So fentanyl patch that works perfect. So
Perfect. Correct.
and especially in those elderlies in which
Yes.
we do not want to intervene, like doing any procedures, and especially is most of our pain management. That yes, they should not be having any sort of pain. So in fact, now, their kids, they're also elderlies. So they have become well trained with giving the dose of diuretics. So this
Yes.
patient was a heart failure patient. They have
Yeah, we can easily give
become well
diuretics.
trained
Correct.
and
Yeah.
that yes, when to give diuretic, when not to give diuretic.
Correct.
So I think it's still a lot way to go in India.
Yeah, it
Especially,
is.
so we are not able to accept that. We want that either it's a recovery or not.
Yeah. It's a lot of training required to, because we understand the concept as Indians. It's very something which is interesting to us, but as somehow we have forgotten it.
Yes.
Like the modern medicine has made us forget we can cure everything. that has come to the doctor's mind, and doctor also starts playing the role. Yeah, I can cure everything, but doctor doesn't realize he cannot cure death. That is something that has to come in his mind. And patient also, at a very, if you talk to them in a very long duration of time, like we tend to have long duration chats, when you talk to them for a long duration of time, and when you ask them what do you really want, then they say, okay, I don't want all this, I just want to be at peace. So like, if there's a very common question which they ask in palliative care or end of life care, they ask, how do you want to die? It's a very important question. And if you ponder about this question, I bet most of you would answer this would be same. I want to die on my bed in my sleep and without any trouble. So when everybody thinks about this in their head, how can we think about putting somebody through, or some of our family members through a ventilator and being tied on a bed? That is very important. So this is a very important concept. So if we want this for ourselves, how can we want not this for our parents, or not this for our children, or not this for somebody whom we love? So this is, and also or for our patients. But somehow we are unable to communicate to our patients, to our family members, to our peers, and that is what is blocking us from completely blooming us. So we know the concept, the ethos are very much imbibed in us, but somehow that expression of it is like, how many of us discuss with our patients an advanced directive, like when they diagnose a serious illness, we don't talk to them that this disease is going to perhaps kill you. Like a patient, if he has a chronic heart failure, we talk to him, you are not going to live with this disease over a long duration of time, and this will probably be the end of you, or it will die with you. And none of us, the physician, have discussion with this, because we don't want to talk this, because if we talk this,
Your
the
patient won't come to you.
attendant will look at us, why are you talking about it? Yeah. That's a very important thing. I think we can have a discussion
Your
on this
patient will
later.
change the doctor.
Yeah, correct.
So that no one wants. It requires a lot of counseling.
It
So
requires,
yes,
there's a very important role of communication in palliative care. How you communicate, how you talk, what is the tone of your voice, what is the setting, what are the people around, how they make it, how they process this information, how a bad news is broken. You give them warning shots, and then you slowly break them up. There's no collision. The main things that we'll talk, I think we'll put it for later.
that it's also important for us to understand the natural history of the disease.
Yes,
that
true.
in what way we explain to the patient.
Yes,
Like,
correct.
yes, this was a starting, how it gradually progressed, and now what will be the end of this disease. Whether at that end point, what we require any intervention, or there is no intervention for that. If there is no intervention, how can we make his life better? So obviously, it's more about making his life simpler and better, rather than having a complications going to the ICUs with all the tubes in different parts. So it's all about how we counsel, and it's still a lot way, I think,
Correct.
just the starting. And along with that, it's also a rehabilitative sometimes in those patients, not just a palliative, it's also a rehabilitative which needs to come in, because most of these patients sometimes they don't have any sort of further advancement in their disease. They just stick in there. So from where, how they can recover or do some sort of things, probably that could also be one of the part. But anyway, it was very nice presentation and very elaborate.
Thank you.
Can I add something here?
Yeah, please do. Yeah.
The one important thing is, it's not in a palliative care. It's not the year of the life you can add in the patient, probably not. But certainly you can add some life.
Yeah, we can add some quality of the life.
Whatever is left.
You're perfectly right.
And second point is ki whenever you are looking a patient for the palliative care, it's not only the medicine or the drugs that are important, rather the psychological angle that will give a big support, or the moral support that is much required.
Very true. Very true. I think that is the whole essence of it. Medicine do less, the physician and his voice do a lot. And that is very right. The ideal aim is to improve the quality of the patient rather than improving the quantity of life. That is very true, sir.
On a lighter note, Nishant.
Sure, sir.
I guess along with a medicine, now it has become Jadoo ki Chappi.
We have to become Jadoo ki Chappi, sir. कोई तो करेगा, नहीं तो सारे बाबा ले जाएंगे.
So definitely it was a great insight, a new perspective to medicine. Definitely emotional support, spiritual support is definitely required. And as Dr. Vaibhav rightly said, as we are moving far from the joint family, the importance of these things are increasing. And probably in India, this is probably some more time that this will be actually in place, but still we are probably not far also that this is going to be reality for Indians also. So that was a wonderful presentation, Nishant. Thank you so much.
Thank you, sir. Thank you, sir.
So with that, any other questions for Dr. Nishant? In that case, should we move to our next session?
Yeah, I think so. Thanks.
So before we move to the next session, a token of appreciation and presentation of a memento and certificate for Dr. Nishant and our chairpersons, Dr. Rupam, Dr. Santosh Gupta, Dr. Prem Prakash, and Dr. Hira Jyoti Sanyal. With that, I would like to move to our next topic with Dr. Manoj Garela. Dr. Manoj Garela has been key person in our association. He has been the president of IACC few years back. Presently, he is governor of IACC, one of the governors of IACC. He is going to talk on an interesting topic about ECG, and that is, what are the ECGs where we clinicians need to have our eyes open. He is clinical cardiologist at Bombay, and he is running a hospital, also a private clinic. The chairperson for the session is Dr. Santosh B from Palikannu, Dr. Alok Sinha from Ranchi, and Dr. Ajit Kumar from Haridwar. We have also Dr. Anil Kulshrestha, consultant physician, diabetologist from Ahmedabad, life member of various societies, including API, IMA, and RSSDI. Chairman at Indian Association of Clinical Medicine, member of API, past president of API Gujarat and Ahmedabad. He is also into social awareness, advisory board, Journal of Indian Association of Clinical Medicine, and he has held various conferences, moderator, chairperson, speaker at national, international, and state conferences, including RSSDI and EPICON. He has expert and principal investigator at clinical trials and post-market drug trials. So, since it's a governor's speech, prior to the presentation, we present the memento and medallion to Dr. Manoj Garela. And from here, I hand over the session to Manoj Garela for his presentation on ECG that won the clinicians. Over to Dr. Manoj.
Yeah, thank you, Dr. V K Jagnany. On this Independence Day, as it's been a trend now and it's been routine, we all wait for this CARDIOZONE webinar conference. Years on years, it's growing day by day, growing year by year. And after this lovely talk, which was actually the need of the current scenario, as you all said, because the joint family trend is decreasing day by day, and in the age, the longevity of the patient is increasing year on year in India. The average Indian age is increasing. And so what we are talking about, the same things, the ECG for a primary physician or a clinician in our day-to-day practice, what we all should know about the basics in ECG and a little bit more about that. Right? Dr. Vineet, am I audible and visible?
Yes, you are audible and visible, but your slides are yet to be here.
Yeah, that's what I was asking you. Yeah, can you please...
Momita, kindly help her.
So, hello.
Hello?
Sir, did you open the PPT? Am I audible?
Yeah. Am I audible?
So,
Yes, Dr. Momita, you are clearly audible.
Yeah. What were you telling? What were you asking, madam?
sir, I'm asking you, did you open the
Regarding...
PPT?
No, I was told that you would run the slides.
I will run the sir. Okay,
You want me to open it?
Sir, you
Dr.
want me
Vineet?
to share the slides from my end?
Yeah, please,
So can you please share the slides? I haven't received, sir.
ठीक है, 1 second, I'll then forward it to Dr. Vineet.
So I'm putting my email ID in the chat box.
Momita, can you share his slide if he is willing like that?
Sorry, sir.
Can you share Dr. Manoj's slide if he is willing like that?
So yes, sir. You
Manoj ji. स्लाइड्स क्या? अच्छा, 1 मिनट देखता हूँ मैं देख के। ओके ओके, I'll just okay.
Madam, did you got the slide from Dr. Vineet?
Yeah, I'm just trying to do that.
Otherwise,
Sir.
Vineet, if you want the next speaker to come ahead and then till the time we do this.
Momita,
Yes, sir.
can you put an email ID for me here
Yes,
on
sir.
the chat box?
Sure. Yes, sir. Sir, yes, sir. I have put it in the chat box.
Just mailing you right now.
Okay, sir. So as I will share the PPT from my end, so whenever it needs to change, just tell me to next. I will move on to the next slide.
Sure. We will do
Okay,
that.
Yeah,
sir.
I'll do that. Yeah.
Okay. Okay, sir.
Yeah, sent. Did you receive it? I have sent the slide.
Just allow me a moment, sir. I'm checking. No, sir, not yet. I'm checking once again. Sir, I haven't received the email. I'm putting my WhatsApp number, sir. Can you please WhatsApp me?
I will not be able to WhatsApp you. I have not got that thing. WhatsApp you.
So can you
I'm
please
sending
check
it.
the sent box, sir? Because I haven't received yet.
Yeah, send box it is showing. I have received the email. I mailed it to myself also. I have received the mail. I have sent it again also.
Okay, sir. Please share. So, you can do one thing as well, sir. You can share the PPT to Namamita. She will share with me. Just send the PPT to her, sir. Yes, sir. I'm telling her to send it to me.
Yeah, is it there? Yeah, Dr. Manoj.
Yes, sir. It is visible.
Yeah, Dr. Manoj, you can take from here. I will be sharing the slides.
Okay, great.
Great.
Yeah. This is we are talking about syncope. This slide, na, Dr. Vineet?
Yes, yes.
Yeah.
This is the first slide.
Okay, great. So yeah. So as we all see in our day-to-day clinical practice, an abrupt and transient loss of consciousness caused by a cerebral hypoperfusion, what we call as a syncope. There are many causes of that, classified as neurally mediated, maybe a cardiac or even a simple orthostatic hypotension. When the blood pressure drops, it can cause this syncopal event. The differential diagnosis include non-traumatic cases and traumatic cases also. Rare causes included subclavian steal syndrome and pulmonary embolism. Acute myocardial infarction, what we see in our clinics and hospitals, acute aortic dissection, which we see less often, but then we see that also, leaking aortic aneurysm, subarachnoid hemorrhage, and cardiac tamponade. There may be the other causes. Next slide, Dr. Vineet. So now talking about a cardiac syncope, yes, it is associated with almost 20% increased morbidity and mortality. Management of cardiac syncope is directed at the underlying etiology. We need to find out that Options include any anti-arrhythmic drugs, the cardiac pacing, and the catheter-directed ablation. So, and it rarely requires implantable cardioverter defibrillator placement also, what we call the AICD. Next slide, Dr. Vineet. So, syncope in hyper-obstructive cardiac myopathy. That is what is, what we everybody is known as HOCM. The Usually the scenario is exertional syncope in persons with family history of sudden cardiac death. Clinical features, it often is asymptomatic. Many a times it may cause arrhythmias, it may cause sometimes chest pain, shortness of breath, or dynamic systolic murmur when we auscultate the patient that intensifies from squatting to standing or during the Valsalva maneuver, which is very important. All of us should do this while check such patients. It involves myocardial hypertrophy of the non-dilated left ventricle and impaired filling, especially at times of stress with electrical disruption and also with variable outflow obstruction. That's why it is HOCM, causing the obstruction. You can see this ECG with the hypertrophic obstructive cardiomyopathic ECG, the classical presentation of the patient with a syncope. This patient comes with a history of syncope, and this is a classical ECG. Next slide, please. And its ECG findings, what we see is the large amplitude QRS complex, consistent with the LV hypertrophy, as we all see, and associated ST segment and the T wave changes. But the main thing is large amplitude QRS complex with LV hypertrophy. Although also there are deep, narrow Q waves in the inferior wall, 2-3 AVF. The lateral leads, the 1 AVL, V5, and V6 leads is perhaps the most characteristic and specific findings. And the large amplitude QRS complex, makes a complex of this hypertrophic obstructive cardiomyopathy ECG findings. Also, then going to the next one, we usually do a 2D echo to confirm that and treat accordingly. So this ECG is important, showing the HOCM part. Next slide, please. Syncope in acute coronary syndrome. Yeah. Syncope in acute coronary syndrome ECG, you can see. Next slide. What we are discussing and what we are seeing over here, it presents diffuse ST segment depression in the lead D1 and AVL leads from V4 to V6 precordial leads with supraventricular ectopic beats. Also, there are supraventricular ectopic beats. As I said before, the echography points out severe and global dysfunction. You can see all the leads are showing the changes. It is not, the one particular area of the wall, but all the leads shows severe and global dysfunction of the left ventricle with hypocontractility of the cardiac wall. So always when we do such ECGs, we correlate with the echo and treat accordingly. And ejection fraction of this patient was only 20% and hypokinetic right side of the heart also. You can now syncope in aortic stenosis. This is also very common, especially in the senior and super senior citizens with degenerative aortic wall. It is a cardinal symptom of aortic stenosis. Many times the finding is, presented with a syncope. Many times the patient is presented with a syncope, and then we do the ECG and echo, we see the patient has aortic stenosis. It indicates for further intervention. Valvular disease, structural cardiac disease, the clinical features, the symptoms depend on the severity of the aortic stenosis. It can manifest with congestive cardiac failure or an exertional angina or syncope, as I said. So many times what we see, the patient is presenting with a syncope or otherwise it with a congestive cardiac failure or exertional angina. But these patients usually tend to, prolong their symptoms and consider it as gas, acidity, and then ultimately presenting it with syncope. Yeah. Syncope in aortic stenosis, you can see this ECG, what we are showing over here with the T wave inversion. Next slide. This you can see the lead to after exercise, but before syncope, and lead to immediately after the loss of consciousness, and lead to after 2 minutes of syncope. Dr. Vineet, can we go ahead? Can we go back to the slide? A is lead to after the exercise. No, I think the next slide. Next slide. Yeah, just one slide before this. Yeah, see this. The A is showing lead 2 after the exercise, and lead the C is representing the syncopal part. You can see the RR interval is increased. Next slide. This is classical of aortic stenosis. Lead 3 after 2 minutes of syncope and lead 3 after 5 minutes of syncope. So the production of syncope is not dependent on the presence of aortic insufficiency. Next slide. The syncope in arrhythmias. Yeah. Now, arrhythmias may be bradyarrhythmias, ventricular tachyarrhythmias, supraventricular tachyarrhythmias. It may be a pacemaker dysfunction if a patient is on pacemaker, or channelopathies. Usually, the scenario is generally abrupt and unprovoked. Palpitations may precede the symptoms. Many a times, patient has this palpitation. Patient comes to know, it's like a pre-syncopal feeling. He gets like I'm about to go in a syncopal trance stage. An abnormal ECG findings is seen sudden onset of palpitation symptoms during or after exertion while in supine or in prone position. It is usually positional also. Next slide. Yes, you can see this long QT syndrome ECG, which is classically showing the QT interval is deranged. Next slide, Dr. Vineet. So the long QT syndrome ECG is seen in this case in a 12-year-old boy without any past medical history, experienced a syncopal event while playing basketball. So this is very common. Patients, school in the school they have an acute syncopal attack and they are brought in our ER. And when we do an ECG, it demonstrates normal sinus rhythm with a prolonged QT interval. So the QT interval was approximately 560 milliseconds. And serum chemistries were also within normal limits. Because of the patient's presentation like syncope, family history, and abnormal ECG, a familial long QT syndrome was suspected. Next slide, please. Now, ventricular tachycardia ECG. This is very common in our ICUs and in our day-to-day clinical practice. The prolonged QT ventricular tachycardia ECG finding has a prolonged QT in a patient with long QT type 1 syndrome. The long QT syndrome associated with particular form of polymorphous ventricular tachycardia, that is everybody knows, very famous torse de pointe. The torsidase may be non-sustained and in such cases could be the cause of syncope. And in that case, however, torsidase may also degenerate into ventricular fibrillation and thereby be responsible for sudden cardiac death. Prolonged QT, yeah. Now, yeah, after torse, the point is what next? What we are is the Brugada syndrome. That is one more important ECG, what everybody in our clinical practice should know. Next slide, Dr. Vineet. Yeah, the Brugada syndrome ECG. Note the complete RBBB with the ST segment elevation in lead V1 to V3. It's a classical presentation with incomplete RBBB, incomplete right bundle branch block with ST segment elevation in leads V1 to V3. Next slide, Dr. Vineet. So here the presentation was a 38-year-old man was presented complaining of 3 brief episodes of severe lightheadedness approximately 30 minutes before presentation. He noted a full syncopal episode. He denied any prior medical history of family history of cardiac disease. And on arrival in the emergency department, his vitals and physical examination was bang normal. And ECG interpreted as normal sinus rhythm with incomplete right bundle branch block and ST segment elevation in the right precordial leads. Next slide. So accordingly, that patient was diagnosed with Brugada and then you have to treat accordingly. Initial EKG showing a high-grade AV block with ventricular rate of 30 beats per minute and a bifascicular block is shown in the ECG. Now, after the syndrome, the torsidy point A, the Brugadas, which we see in less often, what we see more often in our clinical practice, syncope in LV dysfunction, which I'm sure most of us see, on a day-to-day practice. It is unclear if left ventricular diastolic dysfunction plays a role in the pathophysiology of syncope, but many a times when we say before the systolic dysfunction, the diastolic dysfunction happens and occurs first, and you have to diagnose the disease and catch the disease in that stage by doing a normal 2D echo and clinically correlate the presentation clinically. It is more common in patients with syncope. The smaller E by E prime velocities in the syncope group suggest impaired left ventricular diastolic relaxation. As I said before, the diastolic relaxation is affected before than the systolic ejection fraction, indicating LV diastolic dysfunction be one of the clinical predictors of syncope. In a study, they concluded that LV diastolic dysfunction was significantly more frequent in the syncopal group, almost 74% versus 57%, with a p-value of less than 0.001, with a significant p-value. Next slide. So as I said, the study resulted in significant higher frequency were noted in LV diastolic dysfunction. Grade 1 was almost 60% versus 45%. Grade 2 was 13.7 versus 10.6. Grade 3 was 1 versus 0.6 between the syncope and the control group. But as I said, the grade 1 diastolic dysfunction, mostly we see many patients have that, and they have higher chances of this presentation. The mean E velocity of 0.77 versus 0.82, and the E prime velocity was 0.12 versus 0.13, were significantly smaller in the syncope group. So when you have a patient with diastolic dysfunction, you have to be more suspicious, and then you have to be more careful about this. Next slide. Syncope in atrial fibrillation. As we said before, the longevity of the patients, the average age life of an Indian is increasing. So the patients with hypertension and diabetes have dilated LA and then ultimately leading in atrial fibrillation. So many patients now present with atrial fibrillation. We see atrial fibrillation cases. Both syncope and atrial fibrillation are common disease entities. Both lead to a frequent admissions and significant morbidity. Many times with heart failure with reduced ejection fraction or with preserved ejection fraction have a repeated hospital admission. Both are often associated with other syndromes such as sinus node dysfunction and stroke. Both are multifactorial in etiology. Next slide, please. You can see this ECG with atrial fibrillation with a complete heart block, where there is no correlation with the P and the QRS complexes. Next slide. So atrial fibrillation with complete heart block ECG, the heart rate in that ECG we show, it was the ventricular rate was 38. There are no P waves, as the patient had atrial fibrillation and the baseline appears to fibrillate. Thus, there is a new atrial fibrillation with a slow response. The very important finding, so because the baseline appears to fibrillate, which shows it's a new atrial fibrillation with a slow response. Ventricular rate is regular, the QRS is narrow. So there is an inferior ST elevation and ST depression in V1 to V4. So the diagnosis you can make about this ECG, the atrial fibrillation with complete, that is third degree AV block, and inferoposterior ST elevation MI. So if you can catch hold of the diagnosis in this ECG and then confirm with an echocardiography and with cardiac enzymes, you can treat the patient in an early stage and prevent the catastrophe. Next slide, please. So, how to like a simple ECG, if you read it properly and, you catch hold of the diagnosis, it plays a lot of difference in the treatment part of the patient, where when we talk about the door to balloon and the door to needle time, here we should also calculate the door to ECG time. The most important point, and that is even in the primary healthcare clinics, the door to ECG time also should be calculated, what I feel. This is syncope again in atrial fibrillation with a slow ventricular response ECG with a slow, initially there is atrial fibrillation with an average rate of 125 beats per minute. There is sudden ventricular rate slowing. There is a S1Q3 T3 pattern over here which is seen, and in inverted T waves in anterior precordial leads with V1, V2, V3 you can see. Next slide, Dr. Vinny. With a WPW syndrome ECG, which is very peculiar ECG, what we have seen, atrial fibrillation with WPW, Wolff-Parkinson-White syndrome ECG. When you see such ECG, everybody is on an alert mode in the ER. Next slide, please. So it shows a rapid irregular wide QRS tachycardia at a ventricular rate of almost 220 beats per minute and with atrial fibrillation, and there is an antegrade conduction Over the left lateral accessory pathway, RBB configuration, the right axis division with varying QRS widths. So in such patients, you have to accordingly treat the patients, and after the diagnosis, you have to treat him immediately and promptly. Sinus rhythm disturbances. Yeah. Next slide, Dr. Vineet. Sinus tachycardia, yes. It is a very common presentation, even with the physiological and pathological sinus tachycardia, the rate which is more than 100 beats per minute. With fast rates, P waves may merge with preceding T waves and may be indistinct. Can originate from the sinoatrial node, atrial muscle, or atrioventricular junction, often referred to as supraventricular tachycardia, without any specific site of origin, what is seen in this ECG. And the sinus rhythm, yeah, the sinus rhythm with a rate less than 60 beats per minute, that is sinus bradycardia, where you can see the rate is less than 60 and the rhythm is regular. The P waves before each QRS is identical. The PR interval is around 0.12 to 0.20 and the QRS interval is less than 0.12. So this is a classical sinus bradycardia. What we usually tell our primary care physicians and our trainees and our fellows, like you should first identify the normal ECG, then all this sinus bradycardia and sinus tachycardia, that before going to all the syndromes and all the abnormal ECG. So this is a basic what we all should know. Now going to sinoatrial block refers to failure of the sinus node to function for one or more beats. In this condition, there are simply one or more missing beats, that is, there are no P waves or QRS complexes. Fortunately, when the sinus fails to function for a significant period of time, that is what we call sinus arrest, other part of the conduction system usually assumes the role of the pacemaker. So that is how it tries to cover up. These pacing beats are referred to as escape beats and may come from the atria, the atrioventricular junction, or the ventricle. So this is a sinoatrial block. Yes, you can see this. It is classically seen in the DC. The sixth sinus syndrome. Now, again, in the elderly and super senior citizens, the sinus node may undergo degenerative changes and fail to function effectively. Periods of sinus arrest, sinus tachycardia, or sinus bradycardia may occur, ultimately leading to sixth sinus syndrome. Next slide. The premature atrial contraction, or we call it shortly PAC, an ectopic beak arising somewhere in the either of the atrium, but not in the sinoatrial node, occurs before the next normal beat is due and a slight pause usually follows. The P wave may have a configuration different from the normal P wave and may often be of the opposite polarity. Occasionally, the P wave will not be seen because it is lost in the preceding T wave. So this is the premature atrial contraction. The PR interval may be shorter than normal. If the premature atrial depolarization wave reaches the AV node before the node has had a chance to repolarize, it may be conducted, it may not be conducted, and what may be seen in an abnormal P wave without a subsequent QRS complex. So ultimately leading to premature atrial contractions. The premature atrial depolarization waves may be conducted to the ventricular tissues before complete repolarization has occurred. And in such cases, the subsequent ventricular depolarization may take place by an abnormal pathway generating a wide, bizarre QRS complexes. So that is what we see in the premature atrial contraction. Now, after that, the paroxysmal atrial tachycardia, where defined as 3 or more consecutive PACs. The PAT usually occurs at a regular rate, most commonly between 150 and 250 beats per minute. And the P waves may or may not be seen and may be difficult to differentiate from the sinus tachycardia. Next slide, sir. Yeah, you can see the premature atrial contraction and the paroxysmal atrial tachycardia. You can see it simultaneously in both ECGs. Now, the multifocal atrial tachycardia results from the presence of multiple different atrial pacemaker foci. This rhythm disturbance is characterized by a tachycardia with beat-to-beat variation of the P wave morphology. This is a beat-to-beat variation. That's why this is known as multifocal atrial tachycardia, with coming from multiple foci from either atrium. Next slide, Dr. Vineet. Atrial flutter. After we have discussed the atrial fibrillation, The atrial flutter is an ectopic atrial rhythm. Instead of the P waves characteristic sawtooth, please repeat the word sawtooth waves are seen. The sawtooth is a clinical finding of this atrial flutter. The atrial rate in the atrial flutter is usually about 300 beats per minute. However, the AV junction is unable to contract at this rapid rate. So the ventricular rate is less, usually 150, 100, 75, and so on beats per minute. Atrial flutter with a ventricular rate of 150 beats per minute is called a 2-for-1 flutter because of the ratio of the atrial rate. That is, 300 to ventricular rate 150. So accordingly, 150, 100, or 75. Yes, next slide. You can see the sawtooth appearance in this atrial flutter ECG classical. The heart rate is around 200, 220 to 430. Usually the ventricle rate is less than 300. Rhythm may be regular or variable. P wave, as I said, it is sawtooth. The PR interval and the QR cannot be calculated, but the QRS is definitely less than 0.12 seconds. So classical atrial flutter ECG. Atrial fibrillation, here the atria are depolarized and extremely rapid rate, greater than 400 beats per minute. This produces a characteristic wave baseline pattern instead of the normal P wave. But because the AV junction is refractory to most of the impulses reaching it, it only allows a fraction of them to reach the ventricles. And the ventricular rate, therefore, is only around 110 to 180 beats per minute. Although the atrium is contracting as 300 to 400, but it is not reaching the ventricle by AV node, and the ventricle is contracting only around 100 to 180 beats. Also, characteristic of atrial fibrillation is haphazardly irregular ventricular rhythm. Next slide. Yeah, you can see this ECG classical of atrial fibrillation. It is compared classically, beautifully with a normal ECG. Yeah. All these important ECGs should be kept in mind and, accordingly diagnosed and treated promptly. The three types of junctional rhythms, what we are discussing now, are the premature junctional contraction, the junctional tachycardia, and the junctional escape rhythms. I'll repeat: premature junctional contractions, the junctional tachycardia, and the junctional escape rhythm. Junctional rhythms arise at the AV junction. The P waves, when seen, are opposite their normal polarity. They are called retrograde P waves. These P waves may precede, be buried in, or follow the QRS complex. Since the stimulus arises above the level of the ventricles, the QRS complex is usually of the normal configuration. Next slide, sir. Yes, you can see the premature junctional contraction in this ECG can occur since the AV junction may also serve as an ectopic pacemaker. So these are similar to premature atrial contractions in that they occur before the next beat is due, and a slide you can see the premature atrial contraction in this beat. So this is the classical ECG which we see this premature junction. Now talking about the AV junctional tachycardia, the atrioventricular junctional tachycardia, run of 3 or more premature junctional beats has about the same rate as the premature paroxysmal atrial tachycardia and often cannot be distinguished from it. So the difference is not clinically significant. So, you have to be suspicious about the paroxysmal atrial tachycardia and this. Now the AV escape beat, escape beat that occurs after a pause in a normal sinus rhythm. Atrial pacing usually resumes after the junctional beat. And the junctional escape rhythm, defined as a consecutive run of atrioventricular junctional beats, may develop in the sinoatrial node, does not resume the pacemaker role. And the junctional escape rhythm has a rate between around 40 to 60 beats per minute. Atrioventricular heart block. This is also one of the important ECGs, what all of us should know. The first degree and the second degree and the third degree heart block. The second degree heart block is divided again into two, the Mobis type 1 and the Mobis type 2. Next slide, sir. Now, just describing them, first degree heart block, the ECG abnormality is simply a prolonged PR interval to a greater than 0.2 seconds, that is 200 milliseconds. Second degree heart block, Mobis type 1, the characteristic ECG is a progressive lengthening of the PR interval and until finally a beat is dropped. I'll repeat, progressive lengthening of the PR interval until finally a beat is dropped. And the dropped beat is seen as a P wave that is not followed by a QRS complex. Whereas in obese type 2, a more severe form of second degree AV block is seen since it is often progressive to a complete heart block. So that is the difference between obese type 1 and 2. The third degree heart block, also known as a complete heart block, the AV does not conduct any stimuli from the atria to the ventricle. Instead, the atria and the ventricles are phased independently. As I said, there is no correlation between the atrium and the ventricle. The characteristic ECG picture is P waves are present and are occur at a rate faster than the ventricular rate. QRS complexes are present and occur at a regular rate, usually less than 60 beats per minute. The P waves bear no relation with the QRS complex. There is no relation between the P and the QRS. Yeah, you can see in a beautiful slide, the normal ECG, the first degree where it is a prolonged PR interval, and missing that second degree AV block 2:1, and third degree AV where there is no correlation between the P and the QRS. Very important slide this is. Talking about ventricular arrhythmias. Next slide, sir. Yes. The left ventricular hypertrophy, what we are talking, the ECG demonstrated several changes. The QRS complex is widened due to an intraventricular conduction delay. There is a left axis deviation. The ST depression is observed along with inverted T wave noted in several leads. So that's the peculiar finding of LV hypertrophy. And several voltage criteria are met, including an R wave in AVL lead, which is greater than 18 mm. Next slide. Many hypertensive patients, we see this. Next slide, Dr. Vineet. The right ventricular hypertrophy, very classical presentation. If conditions occurs with decreased pulmonary circulation, meaning blood does not flow well from the heart to the lungs, causing extra stress can be placed on the right ventricular. This can lead to RVH, the right ventricular hypertrophy. The ECG changes include the right axis deviation, which is more than 90 degrees. Tall R waves in RV leads with the deep S waves in LV leads. So tall R in RV leads with the deep S in LV leads. Slight increase in QRS duration. STT changes directed opposite to QRS direction, that is wide QRST angle. Evidence of right atrial enlargement is also seen, which is the right atrial enlargement. Next slide, where the P wave is broadened. So many a times you should correlate this with an echo finding, where we classically see the right ventricular enlargement, right ventricular hypertrophy, and the right atrial enlargement. Next slide, please. Yes, you can see this classical finding, what we just discussed with the right axis deviation and the right ventricular hypertrophy, classically seen in the ECG with the HCT changes in V1 to V3. Premature ventricular contraction, many a times, which is in a normal phenomenon in our day-to-day practice, we see our premature beats arising from the ventricle and are analogous to the premature atrial contraction and premature junctional contraction. The PVCs have two major characteristics. They are premature and arise before the next normal beat is expected. That is, example, a P wave is not seen before a PVC, and they are aberrant in appearance. I'll repeat, they are aberrant in appearance. So the PVC has to be diagnosed with this aberrance in appearance. Next, can we see the ECG? Next slide, sir. The QRS complex always is abnormally wide, and the T wave and the QRS complex usually point in the opposite direction. The PVC usually is followed by a compensatory pause. Very important with a compensatory pause. PVC may be unifocal or multifocal. So if it is coming from one foci with a unifocal or multiple foci, it may be multifocal. Unifocal PVCs arise from the same ventricular site and as a result have the same appearance as on a given ECG lead, but a multifocal PVC appearance from the different foci and give rise to a different QRS pattern. Next slide, sir. The ventricular tachycardia, again a cause of emergency in our ER. This is defined as a run of 3 or more PVCs and may occur in burst or paroxysmal. If it is a paroxysmal ventricular tachycardia, you have to treat accordingly. With a continuous runs of ventricular tachycardia, you have to give a DC shock to control it. They may persistent until stopped. The ventricle, they may persistent until stopped by intervention. As I said, the heart rate is usually 120 to 200 beats. Ventricular tachycardia, as I said, is a life-threatening, and you have to treated accordingly by giving a DC shock. Next slide. This occurs when the ventricular fibrillation, what we are talking is occurs when the ventriculars fail to beat, in a coordinated fashion and instead twitch asynchronously. It is the twitching of the ventricle asynchronously. The beats are sometimes divided into a coarse and a fine rhythm. So you can see this ECG where you can see the ventricular fibrillation after the ventricular tachycardia. Next slide. Ventricular escape beats. The ventricular focus may initiate depolarization when a faster pacemaker does not control the rate. They occur after a pause in regular rhythm. If a higher focus fails to pick up the rhythm, ventricular escape beats may continue. When this occurs, the rhythm is called idioventricular and has a rate usually less than 100 beats per minute. The QRS complex is wide and bizarre. P waves may not be present. The idioventricular rhythm are usually of the short duration and require further intervention. Next slide, Dr. Vineet. Yeah, what we are talking about the aberrant ventricular depolarization. Here, the depolarization wave is initiated above the ventricle level, and because it is premature, reaches the ventricular when they are in partially depolarized state, resulting in a wide QRS complex. The following rules can be used to determine aberrant ventricular depolarization. That is, the beat is aberrant if a P wave precedes the wide QRS. The preceding RR interval usually is longer than the other ones, and the most aberrant beats are conducted via the left bundle branch, giving the appearance of a right bundle branch block in lead V1. The initial deflection of the wide QRS is the same direction as that of the normal QRS complex. Next slide. Now, the ECG changes during MI. Yes, now the most important topic what we are discussing, the changes in myocardial infarction. There may be a subtle ECG changes most easily recognized by comparing to the pre-MI ECG. That is what we are seeing over here, before MI and after MI, post-MI. The Cabrera sign, the arrow is seen, is a notched appearance on the ascending limb of the QRS seen in the precordial chest leads. Next slide. So after the important slide, the most important slide, the take-home message, the summary, what we all should, what we are discussing. The pulse rate lies between 60 to 100 beats. Below 60, it is bradycardia, and above 60, it is tachycardia. Rhythm is regular except for minor variations with respiration. The PR interval is the time required for the completion of aerial depolarization conduction through the AV node, bundle of His and the bundle branches, and arrival at the ventricular myocardial cells. The normal PR interval is up to 0.12 to 0.20. That is 120 milliseconds to 200 milliseconds. The QRS interval represents the time required for ventricular cells to depolarize, that is contract, and the normal duration is 0.06 to 0.10 seconds. Next slide. After the summary, yes, the QT interval is the time required for depolarization and repolarization of the ventricles. The time required is proportional to the heart rate. The faster the heart rate, the faster the repolarization, and therefore shorter the QT interval. With slow heart rate, the QT interval is longer. Yes, of course. The QT interval represents about 40% of the total time between the QRS complexes, that is the RR interval. In most cases, the QT intervals last between 0.34 to 0.42 seconds. That is 340 to 420 milliseconds. And the very important, the most important slide, a big thank you to all of you. And it is always good to be a part of this CARDIOZONE conference, which is the key person is Dr. V K Jagnany. It was definitely a short run of slides with, it's a huge topic. As I said, the topic before this could also be a whole day conference, and a topic of this given to me also can be a whole day conference. There are many, many presentations, but at our level and concising this, I hope all the topics are covered, Dr. Vineet. And thank you for running the slides for me. Over to you, Dr. Vineet.
Any comments, questions for Dr. Manoj?
The topic per se
Hello.
is very important, Dr. Vineet, and ECG per se definitely is such a huge topic, and as I said, is a vast sea in himself. So
I guess today's presentation was a classical presentation of symbiosis, where I was
yeah,
sharing the slide and you were talking. But I must say, it seems you have just lost the slide, but otherwise you are so fluent and it was such a lucid presentation from your end. That is highly appreciable. And definitely, you also summed so many thoughts which we have been listening since morning about the various arrhythmias, the coronary syndromes, the syncope leading to various ECG changes, or some ECG changes leading to syncope. I guess this was a good summary on your part. Any questions or any comments for Dr. Manoj?
So, sir,
yes, I'll be happy to. Yeah.
so what should be in your checklist in this in the case of syncope? What should be take home message as for the audience? Just to ask.
The take home message, as I said, in our day-to-day clinical practice, what I said, my what as a normal primary care or a secondary care or a tertiary care physician, what we should see, what I said, what we usually uh, calculate the door to needle time and the door to balloon time, we should also start calculating the door to ECG time. Any syncopal patient should, as the patient receives in the ER, should be done a basic ECG primarily. Many a times, even in the patient, we have seen the patient, the ECG is not done, and directly the patient is, transferred to the CT room and for a CT scan or MR diffusion or an MR angiography. So what the take-home message for is, you should always, all the syncopal patients should have a cardiac evaluation, basic cardiac evaluation with a basic ECG. And of course, with echo, if you have also, that is again a different finding. Yesterday, yesterday in my a patient was referred from a physician where the patient, 32-year-old male, was admitted with a seizure disorder in the hospital, treated accordingly for seizures. But due to some reasons, his cardiac evaluation was not done, his echo was not done, and what we diagnosed with moderate to severe mitral stenosis, so leading to a cardioembolic event. So the take-home message is all syncope should be, evaluated cardiac-wise, clinically before like a basic ECG, and if possible, a echo should be done before the patient is shifted to a CT room and an MR room.
Thank you, sir.
Yeah. I think that was a very good presentation presented and moderated by Dr. Vineet. And I thank you to the team for allowing and giving me the opportunity on this 15th August Independence Day CardioZone. We look forward for many more conferences like this. And over to you, Dr. Vineet, and thank you to the team, and thank you to all chairpersons and all the colleague members. Thank you very much, Dr. Vineet.
Thank you
Yeah,
so
thank
much.
you, Manoj. Thank you, Manoj. That was a revision for all of us. Very nice,
Yeah.
nicely present. Thank you once again, Manoj.
Yeah. Thank you. Thank you. Nice seeing to you, sir. Nice seeing you, sir. Nice seeing you, Dr. Santosh.
Yeah.
Yeah.
Yeah, thank you, thank
I
you.
think we all of us are sitting in our cars and we are doing this. Even you, I'm seeing the previous doctor was in his vehicle. Hello, good, good. Oh, I said a big thank you to Dr. Vineet for organizing this and bringing us all together.
Thank you so much. Just remembering Modi ji, sabka saath, sabka vikas. So you all are here, that's why this is happening. Anyway,
Bilkul,
so
bilkul.
back to the session. Kindly accept the memento certificate presentation also to Dr. Santosh, Dr. Alok, Dr. Ajit, and Dr. Anil Kulshrestha for their chairing the session. Any comments from Dr. Anil? I guess he is here. With this, we would like to move to our next session with Dr. Dipangi. there is some changes in schedule. We are not able to stick to the as planned. Some changes have occurred. Kindly bear with that. So, Dr. Dipanvita will be talking on uses of RNA, initiation of RNA in hospital. How early is actually early? She is a clinical cardiologist at Guwahati and has been awarded for hospital-based study on infective endocarditis and its outcome. She has also been felicitated for Azadi Ka Mahotsav. Chairperson for the session is Dr. Arun More, Dr. Tanushree Lashram, Dr. Sunil Sinha, and Dr. S.C. Datta. With this, I hand over the session to Dr. Dipanvita. Over to Dr. Dipanvita.
Yes, sir. Good morning, everyone. I'm going to talk on this topic of initiation of RNA in hospital. How early is early? So we all know that heart failure, it is a complex clinical syndrome that results from any structural or functional abnormality in ventricular filling or ejection of blood. So here you can see the pathophysiology of heart failure. So the endogenous vasoactive peptides, sympathetic nervous system, and RAS stimulation, it all leads to a state of neurohumoral imbalance. So here you can see, I'm basically talking on heart failure with reduced EF. In acute heart failure, vasoconstriction occurs, which leads to fluid redistribution and pulmonary congestion. And low cardiac output, it leads to fluid retention and peripheral congestion. So in the management of acute heart failure during patient journey, the appropriate timing of its intervention is needed. So in the initial phase, when the patient comes to the emergency department, diagnosis and treatment initiation is done. So in the initial phase, we try to decrease the patient's symptoms. We try to decongest the patient and in ICU and CCU. And after that, the patient can be shifted to ward and discharged. So discharge is the start of the journey. We should try to initiate the 4 pillars of heart failure. Those are AC inhibitor, ARB, and ARNI, then beta blockers, and MRA, that is mineralocorticoid receptor antagonists, and SGLT2 inhibitors, just prior to discharge when the patient is hemodynamically stable and in decongested position. So how do you know when the patient is decongested and ready for discharge? So from patient's weight, NT-proBNP level, and we can evaluate the renal function, electrolytes, and the patient's heart rate. We can do the serial monitoring of the NT-proBNP, that is the natriuretic peptides, during the hospital stay. So management of acute heart failure, short-term management is the treatment of congestion by diuretics and vasodilators, and medium to long-term management, we have to optimize the oral treatment. So here you can see that in the emergency department, ICU and CCU, the immediate measures are taken to improve the organ perfusion and hemodynamics, then restore oxygenation, alleviate symptoms, and decrease cardiac and renal damage, prevent thromboembolism, and minimize ICU length of stay. So intermediate management is done to identify the etiology and relevant comorbidities. And we can initiate the 4 pillars. And mainly I'm going to talk on RNA and uptitrate disease-modifying pharmacological therapy. And pre-discharge, we can do the uptitration and monitoring of the pharmacological therapy. So there are many trials have been studied regarding RNA in heart failure with reduced EF. Now RNA is being studied in heart failure with preserved EF also, but I'm going to talk on the reduced EF part. So one of them is Paradism heart failure trial in stable outpatients with heart failure with reduced EF. already tolerating. They have been getting means high doses of ACE inhibitor ARB therapy. Paradigm heart failure demonstrated that sacubitril valsartan, it reduced cardiovascular death, heart failure hospitalization, and all-cause mortality compared with the gold standard of enalapril. So there was reduction in cardiovascular death, heart failure hospitalization, and all-cause mortality in from the ARNI, high-dose ARNI, when we started the high-dose ARNI versus the high dose of enalapril, that was 10 milligram, and 200 milligram of ARNI was used. But the limitations were that it was studied only in patients who were already receiving stable dose of ACE inhibitor and ARB. That was equivalent to enalapril 10 milligram daily and beta blockers required for at least 4 weeks prior to entry. Only these patients were studied in Paradigm heart failure trial. So the initiation of early in hospitalized acute decongestive heart failure patients feasible after the patient has been hemodynamically stable and not volume depleted. So it can be started when the patient is hemodynamically stable. That is, BP should be more than 100. And if we want to initiate in borderline BP patients, blood pressure patients like systolic blood pressure 100, then we should be careful while administering that. And we should monitor the renal function and potassium every 1 to 2 weeks after initiation of ACE inhibitor, ARB, or ARNI. And the patient should not be volume depleted. He should be in a non-congested position, but not volume depleted. So 2 more trials are there. That is a transition. First is the Pioneer Heart Failure trial done on ARNI versus enalapril. And the second is the Transition Heart Failure trial. So there was a need of Pioneer heart failure trial because of the major limitations of Paradigm heart failure. That was the Paradigm heart failure trial was studied only in stable ambulatory patients, and less than 2% NIHA 4 where patients were there, and there were concerns about hypotension. So here we can see the study design. This was Pioneer heart failure trial. In Pioneer heart failure trial, hospitalized patients with acute decompensated heart failure, that is heart failure reduced EF, that is less than 40%, were studied. And after stabilization, sacubitril valsartan, high dose 200 milligram and enalapril 10 milligram was started. Then they were studied over a period of 4 weeks and then 8 weeks. And evaluation was done regarding the biomarkers, then safety and tolerability, and the clinical outcomes. The key entry criteria in Pioneer heart failure trial was that these patients were hospitalized for acute decompensated heart failure. That means there were signs and symptoms of fluid overload. And LVEF was less than or equal to 40% within the last 6 months. NT-proBNP more than or equal to 1600 picogram per ml. And stabilized patients. After stabilization, it was started. When the patient was stabilized and decongested, these medicines were started, this sacubitril valsartan and enalapril were started. So stabilized patients means in the prior 6 hours, systolic blood pressure should be equal to more than or equal to 100 millimeter mercury, and there should not be any symptomatic hypotension, no increase in IV diuretics, and no IV vasodilators. And in the prior 24 hours, no IV inotropes. The key endpoints were this was noted in the primary endpoint that there was proportional change in NT-proBNP from baseline to the mean of weeks 4 and 8, and safety regarding the worsening renal function, symptomatic hypotension, hyperkalemia, and angioedema. And these were the outcomes, clinical outcomes, serious clinical outcomes like death, rehospitalization for heart failure, left ventricular assist device, and need for cardiac transplant, and expanded composite of heart failure medications, unplanned outpatient IV diuretics. So here you can see in the graph that there was 29% greater reduction in sacubitril valsartan, and the p-value was much significant versus the enalapril group. The safety concerns were similar in both the groups, sacubitril valsartan and enalapril. worsening renal function, hyperkalemia, symptomatic hypotension, and angioedema events were almost similar. P-value was not significant. And regarding the serious composite clinical endpoints, here we can see the sacubitril valsartan, there was much reduction in the composite of clinical endpoints, serious endpoints. Here also the p-value was significant. And rehospitalization for heart failure was much less in the sacubitril valsartan group versus the enalapril group. So the conclusion from the pioneer study was that among hemodynamically stabilized acute heart failure patients with reduced EF compared with enalapril, sacubitril valsartan administered over 8 weeks led to greater reduction in the cardiac biomarker, that is NT-proBNP, and we reduced rehospitalization for heart failure and was well tolerated with comparable rates of worsening renal function, hyperkalemia, symptomatic hypotension, and angioedema. So this study supported the in-hospital initiation of sacubitril valsartan in stabilized patients with acute decompensated heart failure and reduced EF, irrespective of prior AC inhibitor or ARB use or prior heart failure diagnosis. So if any patient is using AC inhibitor or ARB, so how to transition from AC inhibitor ARB to RNA? So key points from pioneer heart failure was that the most important was that for a patient on an AC inhibitor, we can withhold it for 2 dosing intervals. That means we should allow a washout period of 36 hours and then start sacubitril valsartan. And if the patient is not comfortable with this strategy, there's an option to give 2 doses of valsartan before starting the sacubitril valsartan. In the transition study, sacubitril valsartan versus sacubitril valsartan initiation was done pre-discharge and post-discharge. So the patients, it was study results was dependent on reduction of NT-proBNP less than or equal to 1000 picogram per ml or more than 30% from baseline. So it was studied over a period of 4 weeks and then 10 weeks. So in the transition study, randomized, it is a randomized trial of pre-discharge versus post-discharge initiation of sacubitril valsartan. It was seen that the serious cardiac events, adverse effects, were similar in both pre-discharge initiation and post-discharge initiation. They were the cardiac failure, acute renal injury, hypotension, hyperkalemia, and mortality. They were almost similar in both the groups. So the conclusion from this one transition study was that about 50% of the heart failure of reduced EF patients stabilized after an acute decompensated heart failure event achieved the recommended dose of 200 milligram sacubitril valsartan twice daily within 10 weeks. So with 200 milligram sacubitril valsartan, it gives the maximum benefit. And it was found out that 50% of the patients in whom it was started could achieve this dose. Sacubitril valsartan can be initiated early and safely in patients shortly after acute decompensated heart failure. The number of patients who made the primary and secondary endpoints was similar across the both treatment arms. And the incidence of adverse events and discontinuation of sacubitril valsartan due to adverse effects was almost similar in both the in-hospital and out-hospital setting. So here all the three has been compared. That is pioneer heart failure and transition heart failure. So pioneer heart failure trial was done in inpatient setting, and transition was done mainly the drug was started in the hospital or after discharge, pre-discharge and post-discharge. So this is a comparison of all the three. So here we can see the adverse effects of worsening renal function, hyperkalemia, and cough they were much lesser in the sacubitril valsartan group. So in titration guidelines, titration of sacubitril valsartan, we should ensure a washout period of around 36 hours for patients taking an AC inhibitor. And we should check the systolic blood pressure prior to each dose increase. So doses should not be increased for patients with systolic blood pressure less than 110 millimeter mercury at day 7 or less than 100 millimeter mercury at day 14 or thereafter. And we should also monitor the renal function and the potassium level. So from these trials, we can understand that initiation of an ARNI de novo without prior exposure to an AC inhibitor or ARB is preferred. So recent data suggests that directly initiating an ARNI rather than pre-treatment with AC inhibitor or ARB is safe and effective. And patients with de novo heart failure who underwent in-hospital initiation of an ARNI has greater reduction in natriuretic peptides, a comparable safety profile, and a significant improvement in early clinical outcomes compared with those already on medications. When de novo initiation of ARNI is performed, close follow-up and serial assessment should be done of the blood pressure, electrolytes, and the renal function. And we should monitor for the risk of angioedema and hypotension. So comparison is done between all the three trials. And in conclusion, we can say that ARNI based on the Pioneer Heart Failure Study for patients with heart failure reduced EF hospitalized for acute decompensated heart failure who are in a transitory phase towards stabilization and who have stabilized after initial diuresis or who are in the transition to discharge period. ARNI can be started. And when initiated in the hospital after stabilization of acute decompensated heart failure, it is recommended that patients are clinically stable. That means no symptoms of hypotension, no increase of IV diuretics, vasodilators, or nitrate therapy in the prior 6 hours, and no IV inotropes in the prior 24 hours. Thank you. So nowadays, ARNI has been one of the pillars of this one heart failure, along with MR, this one beta blockers and spironolactone, eplerenone, and SGLT2 inhibitors. It has been used recently, and good this one results have been found.
When we talk of heart failure, invariably we say that beta blockers, MRAs, ARNI has to be there. Definitely, ARNI has taken over ACE and ARBs. No second thoughts about it. Where do you place loop diuretics or thiazide type diuretics in management of heart failure along with the standard treatment, which involves these other drugs, beta blockers, ARNI, MRAs, and SGLT2 inhibitors? So where do you place loop diuretics or thiazide type diuretics?
Sir, loop diuretics and this one thiazide diuretics, mostly loop diuretics, it doesn't have any this one mortality and morbidity benefit, but it causes symptomatic relief. Means in decongestive heart failure, it helps in decreasing the volume overload. So in the initial phase, when the patient comes to the emergency department in acute LVF, so it plays the most important role. And during the patient hospital stay, gradually you can decrease the loop diuretics and increase the other dosage of this beta blockers, MRA, according to the BP and other this one monitoring the other renal function.
We agree that in symptomatic patients or when we are suspecting volume overload, loop diuretic has its own own place. So we also talked about hyperkalemia when we are talking about ARNI, specifically when MRA is co-prescribed. So
Yes.
there also, do we see any place for loop diuretic? That will that help in preventing or reducing the incidence of hyperkalemia?
Loop diuretics. We can try that, sir, but mostly in our settings, this one, loop diuretics is mainly used for this one, decreasing the volume overload and the congestion.
Fully
And
agree.
in
Fully
case
agree
of
with you.
in hyperkalemia cases, we can stop the factors causing hyperkalemia, and like ACE inhibitors, ARB or whatever, MRA, we can withhold that for a few, and sometimes beta blockers also. So we can withhold those medicines for a few time after the hyperkalemia is treated, and we can continue this one, no? Nebulization and all the medications given for K-bind SACHE, potassium reducing this one, and later on we can gradually start the dose of ACE inhibitor, ARB or beta blockers after hyperkalemia is treated.
Fully agree with you that the co-prescription of MRA with ACE-ARB or ARNI is very much prone for hyperkalemia, specifically if the creatinines are high or renal involvement is there. So in that case, we can stop these drugs and we may co-prescribe. And if there is recurrent hyperkalemia, probably one of the drugs may be stopped, despite having mortality benefit with these two drugs. So sometimes co-prescription has to be avoided to prevent hyperkalemia, and loop diuretics, no doubt, is more so for volume overload or symptomatic patients. I have also observed, and books also suggest that if the patient is dyspneic or symptomatic, probably we need to continue loop diuretics in some of the patients, maybe not all, but some of the patients.
Yes, sir.
So, any other comments or questions for Dr. Dipanvita? That was a wonderful presentation, an insight into ARNI, which is a mainstay treatment in management of heart failures. So definitely, thank you so much, Dr. Dipanvita. Any questions, any comments for Dr. Dipanvita?
Thank you, sir.
Yeah, this was a wonderful presentation, Dr. Dipanvita. I
Thank
would
you.
also like to add that these patients, these patients always present with borderline blood pressures.
Yes, ma'am.
So instead of stopping these drugs altogether,
Yes,
it's
ma'am.
always better to kind of follow them up closely and give whatever small amount of ARNI or say SGLT2 inhibitors. All these drugs should be clung to and should be continued in these patients to give them maximum benefit.
Yes,
So
ma'am.
the doctors need to have a lot of patience and kind of cut out the treatment for every patient individually as per his body response.
Yes, ma'am. In our setting, ma'am, we used to, in such patients, borderline BP, who have borderline BP, like 100/70, 110/70, few of those patients, we used to give half of the dose of 50. ARNI 50 mg, half BD. We used to start gradually, and gradually we used to titrate accordingly. Increase the dose, up titrate.
I agree with you, Ratna ma'am. I guess management of heart failure is like cooking a good vegetable, जहाँ थोड़ा थोड़ा हर मसाला पड़ता है, वैसे ही in management of heart failure, we should try to give all the molecules for their maximum benefits to the maximum tolerable dose which the patient is able to tolerate. I fully agree with you, ma'am. Any other thing? Any other comments, questions? In that case, we should move to our next session.
Thank you, sir, for giving me the chance.
Thank you. Thank you so much, Dr. Dipanvita. Kindly stop sharing this thing so that
Okay, I'm trying.
You'll see an option in red. That's Momita, you can help Dr. Dipanvita.
Ma'am, are you getting the option of stop share?
I couldn't find it.
Middle of the screen, ma'am. Top.
The screen.
Just 1 minute.
Zoom out is there, zoom out.
Yes, I hope
Thank you.
it is stopped now, right?
Thank you. Yeah.
Okay.
Thank you so much. So before we move to our next session, a token of appreciation, presentation of memento and certificate for Dr. Dipanvita and our chairpersons, Dr. Arun More, Dr. Tanushri, Dr. Sunil Sinha, and Dr. Siddhartha sir. Thank you so much. Moving to our next session, that will be CARDIOZONE oration from Dr. J.P. Santamarai Samuel. She is from Chennai, clinical cardiologist, the senior most person in our association. She will be talking on Eisenmenger syndrome. She has done so many cardiac OPDs along with so much charity. She has also been part of various national and international clinical trials. She is lecturer and examiner at various educational institutes. She is also faculty at Apollo Hospital, Chennai and Cardiac Rehab Center. She worked as clinical assistant at the same hospital. She has been chairperson and a speaker at various conferences. She's a life member of IACC and involved in drug trials in newer medical education teaching methods. She has a special interest in preventive and reversal of cardiovascular disorders. She also takes part into social medical camps, and she has been athlete with the gold medalist in intermediate javelin throw and also a chorister. To chair the session, we have Dr. Umesh Kashyap, Dr. Indra ma'am, Dr. Abhishek Sarma from Palampur, Bhubaneswar, and Katni, respectively. Since it's a CARDIOZONE oration, we'd like to present ma'am with medal and memento and certificate prior to the presentation. With this, I hand over the session to our chairpersons and Samuel ma'am. Over to you, ma'am.
Ma'am, are you, just for the confirmation, are you facing any difficulties to share the screen?
Momita, you could be helped to Dr. Samuel ma'am.
I already
Am I
asked her. Hello. You are muted.
Yeah, am I audible now?
Yes, ma'am. Ma'am, can you please share
Okay,
your
then
screen?
I'll go ahead.
Ma'am, it seems like the network bandwidth is slow, ma'am. Your video got stuck.
Yeah, are you able to see the screen?
No, not yet, ma'am.
Screen share now.
Have you shared the screen? Yes, it is coming
Oh,
now. Yes, ma'am.
yeah,
Next screen.
it's coming now. Oh, yeah. Next slide. 1 minute. I just want to. I'm talking about Eisenmenger because we had 2 cases of VSD Eisenmenger and 1 case of single ventricle, and that is why I chose this topic. And now, am I okay? This is the outline of this. First of all, we want to see the history and the definition and the rest of it. So when you go to history, It was in 1897, Dr. Victor Eisenmenger found out this on a 32-year-old man with VSD and cyanosis. So that is why it is named after him. Then Dr. Paul Wood, he is a father of cardiology, was born in Kunnur in our country, in Tamil Nadu, and he actually gave this definition. And finally, the AHA has given this final definition, which says that Eisenmenger is defined as pulmonary hypertension at a systemic level caused by a high pulmonary vascular resistance with a reversed or bidirectional shunt at aortopulmonary, ventricular, or atrial level. For convenience sake, we classify the congenital heart disease, which later on become Eisenmenger, into groups: acyanotic and cyanotic. As we all know that acyanotic group, we have AST, VST, PDA, and AP windows. Initially, they have normal blood flow to a pulmonary flow will be normal, and later on it will become increased. And once the left to right shunt becomes more and more with more pulmonary flow, there will be shunt lesion, and with increased pulmonary flow leading on to Eisenmenger. In the case of congenital heart disease, we have truncus. Cyanotic congenital heart disease, we have truncus, TGA, trachea, AV canal defect, TAPVC, hypoplastic left heart syndrome, MAPCAS, VST with interrupted aortic arch. Here in this case, there will be intracardiac mixing. The causes of Eisenmenger syndrome we have in different presentation also. And this is what happens to the pulmonary artery with Eisenmenger syndrome. The vessel wall becomes thicker. I'll later on explain the details about it. Now we deal with the acyanotic shunt lesion. The history in the children, initially there will be murmur, and then the pulmonary vascular resistance will be high, there will be murmur, and then cyanosis also will be in infancy. Then later on it will disappear, and children will have dyspnea and exercise intolerance. In the case of adults, there will be hemoptysis, chest pain, syncope, fatigue, and cyanosis. We come to the next portion, that is clinical manifestations. On physical examination, we see clubbing, cyanosis. JVP may be elevated in the presence of RVF. There will be prominent A and B waves. And on inspection, we will be seeing dynamic heart. On palpation, we are going to see feel the parasternal heave. P2 will be out and felt, and hepatomegaly in case of right heart failure and ascites and peripheral edema. The auscultatory finding will be P2 will be loud. There will be pulmonary ejection click because of the dilatation of the pulmonary artery. And because of the RV failure, there will be RVS3 and RVS4. And there will be systolic murmur of TR and high-pitched diastolic murmur of, which is called Gram-Steele murmur. The other findings we see is respiratory. Because of cyanosis, we see the patients with tachypnea. And there will be hematological signs, bruising and bleeding. And there will be fundoscope abnormalities also. And when we see some fundoscope, plots of hemorrhages, microaneurysms, papilledema, and lot of vessels. Abdominal, due to failure, there will be jaundice. There will be right hypochondria, tenderness, and the Murphy sign will be positive in the case of cholecystitis. Is one of the complications of this problem. Cyanosis, high PCV and HB. And vascular is postural hypotension and focal ischemia, which could be because of paradoxical embolus. Musculoskeletal, we know that clubbing is there, and hypertrophic arthropathy will be seen. Ocular signs, because of hyperviscosity, we will be seeing these things. This is the typical clubbing and cyanosis. Then we go for investigations. Investigation, we go for blood analysis. Because of compensatory erythrocytosis, there will be increase in whole blood viscosity. Hemodynamic abnormalities will be noted in 20% of the patients. Bleeding tendency, mild, superficial, or maybe leading to bruising. And there will be increase in PTT and potential thromboplastin time. And the clotting coagulation factors also will be reduced coagulation factor in 5, 7, 8, and 9. There will be quantitative and qualitative platelet disorder and increased fibrinolysis, thereby systemic endothelial dysfunction will be noted. Increased HB and PCV, and these patients will have iron deficiency, hyperuricemia because of increased red cell turnover, and blood gas analysis will be low. ECG, there will be right atrial enlargement, right ventricular hypertrophy, right axis deviation, as in the case of ostium secundum lesion. Features of LV enlargement plus RVH in PDA and VST. KW phenomenon will be seen in case of VST, where you see 2 to 3 equiphasic QRS complexes in the mid-precordial leads. There will be PTA and flutter seen in AS because of the RAE and LAE also. Right, left axis deviation and northwest axis will be noted in primum interval prognostic, poor prognostic markers. This is the ECG where you can see the RV with right axis deviation. It is almost like 90 degrees minus. Radiological signs. There will be right-sided aortic arch in 60% cases of VST. The aorta will be inconspicuous because there is not much blood flowing through your aorta. Rounded shadow overlying the aortic knuckle is a reason for, PDA is a reason for it. There can be calcification of the duct also. The main thing is dilatation of the main pulmonary artery, 90%, RPA and LPA. There will be pulmonary oligemia because of the increased vascular peripheral resistance, and peripheral pruning of the vessels will be noted. PDA and VST, normally there will be radiological finding will be either slight increase in CT ratio. Whereas in the case of AST, the CT RV dilatation. This is vascularization. The vessel wall becomes with increased concomitant increase occurs in the neovascularization of the vasa vasorum, which occurs primarily in the adventitia and later on it. That's how this happens. This is a very specific sign for this Eisenmenger. This is a X-ray picture. We all know it. Internet connection. Internet connection. Finding, we are all the PGDCs are experts in echoes, so I don't need to say much about it. Transthoracic, we can see severe RVH, RAE, the function, RV function may be initially normal and later on it becomes abnormal when the RAE happens. Left LV appears small, underfilled. Sputum, septum deviates towards the left. LV in the case of AST. In the case of VST, there is pressure equalization and increased TR velocity which used to estimate RV systolic pressure. PR with high velocity regurgitant jet will be found in VST. MR is also present in the case of AV canal defect. These are the echo predictors, as we all know. Then this is because I didn't want to have all the defects and show that only this ASC and biggest lesion I'm showing. Then invasive evaluation. We have cardiac catheterization. It must be done in borderline cases to assess the operability. Response to pulmonary vasculature, to pulmonary vasodilators like O2 and talozolane and nitric oxide should be assessed when we do cardiac cath. Contrast, we have to use very carefully in a minimal way. In the case of acyanotic shunt lesion, the management plan is, if it is left to right shunt feature, we can straight away go for surgery or device. In case of RV to RA to LA shunt, reversal of shunt, if there is Eisenmenger, nothing much can be given for the patient. Case of borderline feature, if it is operable, then we'll give them surgery or device. Inoperable Eisenmenger. The borderline cases are the ones we are going to take for right heart study. In case of normal children, we can review them once in 2 years. But in the case of Down syndrome, we have to review them earlier, 6 months to 1 year. When we are in the position where we are not able to find out from the hemodynamic data what to do, what is the reversibility condition of the PAH, we have to do open lung biopsy. Plan for cyanotic heart, congenital heart disease. In case of increased blood flow in the early infancy, we have to do PA banding to control pulmonary blood flow within 4 to 6 weeks. Maximum, we can go up to 3 months. If it is not done at the right time, the child will go in for Eisenmenger. In case of complex congenital heart disease, TGA, we are going to do arterial switch operation. In case of TAPVC, we have to connect the vessel in the right place. Single ventricle, first 6 months, we'll do Glenn, SVC to PA. Then we'll do 18 to 36 months, we'll plan for Fontan, IVC to PA. Management, this one right heart study. We have to do AVT study, acute vasoreactive study, and we have to do occlusion test, a unilateral pulmonary occlusion test, which we do it post-operatively when the child is operated. In medical management, we have to see if the PVRI is less than 4 Woods unit, we can plan for repair. If it is between 4 and 8, we have to assess the child. If it is more than 8 Woods unit and the PVR SVR ratio is more than 1.15, nothing, we cannot give any intervention cannot be done. Medical management, borderline case, we'll do pulmonary, we will give them pulmonary vasodilators, 4 to 6 months, recath. This is AHA guidelines. Then pulmonary vasodilators, with the study of AVT, we can plan whether we can use single drug or dual drug. Then we have to follow up the patient once in 6 months. Then when we follow a patient with once in 6 months, echo, echo and RV function should be, echo we do RV function, NT-proBNP, if it is normal is 125, if it is more than that, we have to. And then 6-minute walk test is very important. If the meter distance is less than 350 meters, we have to be careful. That's how we assess a patient. Then yearly follow-up we do to check all the other organs, because as they grow old, we have to think of diabetes, hypertension, and dyslipidemia, because comorbidity will happen. And in case of failure, we'll do diuretics, antiarrhythmics, anticoagulants, long-term oxygen therapy, treatment for anemia. And we have to avoid dehydration, high altitude, flying in the aircraft is also sometimes very careful. We have to be careful. Infections and IV lines, avoidance of pregnancy, moderate to severe strenuous exercise, should be avoided, particularly isometric exercise. We have to be very careful about IE prophylaxis, renal impairment, gout, and cholecystitis. We have to look for all that. These are the complications, as you all know, I've already mentioned. And these are the mortality predictors. Depends on the heart failure, the class NYHA classification, heart failure, features of right heart failure, and ECG changes. As I said, QTC and QR widening, important. Arrhythmia is important. Complex congenital heart disease, they're more prone for mortality. Creatinine, uric acid, we have to be looking for our renal function test. Pregnancy is very dangerous because both there will be infant and fetal mortality as well as mothers. And syncope and this, we have to look for left heart. Complex heart disease, we have to look for LV dysfunction also. Phlebotomy is done, moderate to severe when the PCV is more than 65%, because there will be hyperviscosity and there are a lot of hyperviscosity symptoms will happen. We have to advise the patients. They have to, once in 2 months, they have to check the HbPCV. Iron and uric acid along with HbPCV should be done once in 6 months. If PCV is more than 60%, there can be neurological and other organ complications. Iron deficiency will be noticed because of high PCV, and we have to treat the iron. And they have to watch for bleed. Hydration is very important. They lose weight a lot, so we have to check the weight management, and nutrition is part of it. Then occupational, quite a number of them feel terrible because they cannot do anything. So we try to treat them with occupational therapy and rehabilitation. Most of them go for mental depression. So we have to, psychologists should be advising them what to do, how to cut. In case of women who are married, they have to use intrauterine device to prevent pregnancy. Premarital counseling is very important. Target therapy, as we know, these are the vasodilators, different types of vasodilators we use. And surgical management is, that is transplant. If RV function, dysfunction is there and irreversible RV damage is there, then we have to go in for heart-lung transplant. If the RV dysfunction is there, which is going to be reversible, no scar, we can plan only for bilateral lung transplant. We have to do right heart catheterization, thermodilation test, and pre and post pulmonary transplant pulmonary gradient should be checked to see post-operatively how the patient is doing. The natural history of the disease is the patient with defects that allow free communication between the pulmonary and systemic conduit circuits at aortic and ventricular levels are fairly healthy childhood and cyanotic during the second and the third decade. Exercise intolerance is proportional to the degree of hypoxia and cyanosis, and gradually decline in physical activity survive till childhood. 77%, 42% survive at 15 and 25 years respectively. Congenital heart failure after 40 years, most common mode of sudden death. So most common mode of death is sudden death at 30%, could be embolization or arrhythmia, then congestive heart failure, and rest by pregnancy, perimortal or perioperative mortality, non-cardiac, and infection, i.e. and brain abscess. The future perspective is we want to reverse the damage our pulmonary vessels by use of iloprost inhalation, then inhibition of phosphodiesterase group 5, and activation of soluble gluconyl cyclase and gene therapy. These are the things, or we can combine all of them and see. This is the end, and we had a patient, two patients, Geeta and Pushpa. 2 of them were VSD Eisenmengers. They lived up to 45 years. We had another ASD, small ASD, my doctor's mother. She lived up to 60 years. And later on, she developed complications. We had a boy of 15 years. He was operated. He had single ventricle left a single LV, single ventricle. And I think he was operated and he survived up to 15 years. And now I want to thank our IACC family for giving me a chance and to present this. Dr. Vinay Jagnany is all the time after me. He's a wonderful doctor. And he is actually encouraging me to do this. I normally have stage fear, and he's the one who has put me into this. I thank him. I thank Dr. Jyoti, who is a PGDCC, my junior, and Dr. Anuradha Sridhar. We all work together in Frontier Lifeline, Dr. K.M. Cherian's hospital. She's a pediatric cardiologist, FNB, and she suggested me how to present. And I thank Dr. David, who's none other than my son, who helped me to do all the slide preparation and presentation. I thank one and all for participating in this independent Zoom meeting. God bless you all. Thank you.
Great presentation, ma'am.
Thank you. Thank you. Am I audible?
Yeah, little bit, little bit.
Okay. I think the speaker doesn't. That is why I think that it's there. And the patients with Eisenmenger, patients, two of them with Eisenmenger, we had to do repeated phlebotomy. And they are, both of them passed away. They lived up to 45, and that was fair enough, no? Thank you. Any question? I'm not able to hear you.
Any questions or comments for ma'am? I guess ma'am has covered wonderfully Eisenmenger's starting from history to future perspectives. How we all started for Eisenmenger's and what do we see in the coming time. So hats off to you, ma'am, for your lucid presentation, wonderful detailed presentation. Thank you so much for that.
Thank you.
Any questions for ma'am? In that case, we can move to the next talk. Momita, can you help us?
Definitely, sir.
So that I
So
can
you want me
share
to
my...
stop the skin sharing, right?
Yeah, exactly.
Okay, okay.
Thank you so much.
Thank you,
Thank
sir.
you. I can remove this.
So we move to the next session. Before that, we'd like to present memento and certificate to our speaker and chairpersons, Dr. Umesh, Dr. Indra ma'am, Dr. Abhishek Sharma. Thank you so much for your cooperation and time that you have been here. We are a little bit changing the schedule. Next session, we have Dr. Mitesh with us. He is clinical cardiologist at Surat, and he will be talking on strain echo. To chair the session, we have Dr. YGK Reddy, Dr. Iklaq Khan, Dr. Ziaul, and Dr. Deembandhu Sahu, who is here from Bhubaneswar, Jaipur, Devghar, and Bhavani Patna, respectively. Thank you so much. Over to Dr. Mitesh for his presentation.
Good morning, everyone. How do I share?
Sir, just open the PPT, sir. It's very
It
simple,
is
sir. Yes, sir. And keep it minimized.
okay.
Yes, sir. Now, come back to the Zoom meeting, sir. And you will get an option, share screen, green option, middle of the
Okay.
screen, sir.
Yeah. Now share.
Now shared. Yes, sir. It is not coming. Yes, now it is
गुड मॉर्निंग
coming.
सर, आप तो थे अभी, निकल गए अभी, आपका ही सेशन चालू है चेयरपर्सन में।
Make it full screen, sir.
हाँ, जस्ट नाउ थोड़ा सा शेड्यूल ऊपर नीचे हुआ है, तो इफ यू कैन काइंडली ज्वाइन। थैंक यू सो मच।
Sir, make it full screen and please go ahead with the presentation.
Is it fine? Slides are visible?
Yes, sir. Slides are visible, sir. Is it possible to make it full screen?
I think I have made it. It is full screen on my laptop.
Somehow your voice is echoing, sir. Okay, it is full screen, but it is not showing full screen from our end.
Should I go ahead or do you suggest anything?
Yes, sir. Please go ahead, sir.
Okay, with the permission from the chair and organizing chairman, my dear friend Dr. V K Jagnany, bottom of my heart, I thank all of the organizers and I wish all our citizens a very safe. And topic today for our discussion is basic introduction to cycle tracking echocardiography, commonly known as train echo. So, train echocardiography is a non-invasive ultrasound technique for objective evaluation and qualitative evaluation of globe as well as regional myocardial function. So what we are commonly doing and is in practice for so many decades is conventional ejection fraction by visual interpretation of endocardial motion and myocardial thickening. And it is subjective and requires a relative experience before we can, match up to the seniors and we can come to the qualitative and quantitative analysis and get to the real ejection fraction. But as we all know, and as we have practiced in our day-to-day practice, that it is being hampered by dropout and trabeculation. So, with the introduction of tissue Doppler imaging, things have become simple, where tissue Doppler image measures myocardial velocity and the net effect of contractile and elastic properties of the area under investigation and the motion caused by the traction and damping gives our tissue Doppler a value that gives us underlying this myocardial function. But we all also face this angle dependency during our tissue Doppler interrogation. So whereas in this strain echo, strain is a dimensionless index and it reflects total deformation of myocardium during the cardiac cycle, and it is being reported as a percentage of its initial length. Strain rate is rate of deformation or a strain. So as we discussed, the advantages and disadvantages of strain, cycle tracking echocardiography, and tissue Doppler echocardiography. So let us first understand about human myocardium. Human myocardium has multiple layers, whereas in helical model, it has been suggested that single myocardium muscle band is being folded upon itself and giving a complex value mechanics, where Whereas in systole, there is the inward movement, longitudinal motion, and twisting. And in diastole, opposite of this, all motion happen. So systolic twist and early diastolic untwist around the long axis happens in cardiac cycle. And in 1 second, 1 second.
Sir, you there, sir?
Dr. Nitish just called up. He's joining in a minute or so. Kindly hold on.
Sir, he has left the meeting. It's only possible for the network, sir, poor network. So we can wait for sir.
Somehow his battery got down. He is just putting a charger and then he will get back.
Okay, sir. We can wait for him.
In the meantime, our next speaker is ready. Dr. Sheetal is there. So
Good morning, sir. Can I just share my slide till then and just check if everything is okay?
yeah, in the meantime, I guess you can do that. Thank you so much, Dr. Sheetal.
Is it seen? My slides are seen?
Yes, ma'am.
Yes, ma'am. Visible. Make it full screen, ma'am.
Yeah. Shall I start or shall we wait for Dr. Mitesh in the meanwhile?
It's a good idea. We can continue. Dr. Mitesh will present after yours. No issues.
Okay.
Not a bad idea.
I'll start then, sir, with your permission.
Sure. Please go ahead.
Yeah. Slides are clear, right? It's seen now?
Just make it full screen.
Yeah, now?
Yeah, now it's full screen.
Yeah, okay. Now is it seen? I'm not able to see my slides now.
Yeah, please.
Okay. Just a few minutes, yeah. Fine. So good morning, good afternoon, everyone. First of all, let me wish you all a very happy Independence Day. I'm audible, clear?
Yes.
Yes, ma'am.
Sorry, so I'll continue. So today I will be talking about, first of all, thank you, Dr. Vineet, sir, for, as usual, keeping me on my toes so that I can read up something and be ready to talk here with some difficult questions as well from Vineet, sir, coming up. But I'll be ready to answer them as well. I'll try my level best. So today, what he asked me to talk was on oral hypoglycemic agents in diabetes type 1 diabetes mellitus. My first thought was like, really, what am I supposed to talk on it? Because the kind of challenges that we face with type 1 diabetic patients especially are, most of them are very young. Like the youngest child that I must have seen was around 7-year-old. That child, it was the most difficult part is when we start insulin even in very young age group patients, even adult patients. But then here it was the question of starting insulin for a 7-year-old child. So that can actually be challenging because Hello? Hello?
Yes, madam, you are audible.
Ma'am, you are audible, ma'am. Please
नितेश
go ahead.
नितेश थोड़ा सा गड़बड़ किया हम लोगों ने, तुम्हारे एब्सेंस में शीतल का चालू कर दिया है, शीतल के बाद तुम कर लेना. इट्स ओके आई गेस.
Yes, sir.
ओके,
Yes,
थैंक यू.
sir.
My
थैंक यू सो मच.
seen, sorry, my slides are not seen. Sorry. Let me start with the talk right away. The incidence of type 1 diabetes, the incidence of diabetes in the world, Southeast Asia and India was 10%, 10.5%, 8.8% and 9.6% respectively throughout 2021. And it is expected to rise to 12.5%, 11.5% and 10.9% respectively by 2045. So in India, it is expected to rise to 10.9% by 2045. Now, coming to type 1 diabetes, type 1 diabetes is a bihormonal disease. It is characterized by destruction of the pancreatic beta cells and resulting in severely impaired or absent insulin secretion combined with abnormal alpha cell function with excess glucagon in the fasting and postprandial state. Insulin therapy, however, remains the cornerstone of management. So what is the ideal treatment of type 1 diabetes? It should be improving HbA1c without increasing the risk of hypoglycemia. It should help us to hello.
Ma'am, are you facing any difficulties?
Hello.
Yes, ma'am. Are you facing any difficulties?
My screen is not getting shared from my side.
No, it is already shared, ma'am. We can see the slides. Do one thing, ma'am. Stop the screen sharing and reshare.
We actually started to save some time and this is taking everybody's time. Okay. Let me see. I'll just keep it like this instead of, my screen is seen now?
No, ma'am.
It's seen now?
No, ma'am. Not yet.
Now?
Yes, ma'am. Yes, ma'am. Visible.
I'll not increase. I mean, like, I'll not maximize this slide. I'll be just
You
stop.
don't need to maximize the slides, ma'am. You just need to make it full screen.
Is my screen is seen now, right? I'll start once again. I'm sorry. I'm sorry about this. My slides are seen now.
Yes, ma'am. Visible. Please go on.
Can I start, Vineet sir? Sorry, everyone. Okay. So the incidence of diabetes in the world, Southeast Asia and India was 10.5%, 8.8% and 9.6% respectively throughout 2021, and it will rise to 12.5%, 11.5% and 10.9% respectively by 2045. So the incidence of diabetes is increasing day by day. Now, diabetes is a bihormonal disease which is characterized by destruction of the pancreatic beta cells, resulting in severely impaired or absent insulin secretion, combined with abnormal alpha cell function with excess glucagon in the fasting and postprandial state. Insulin remains the cornerstone of management. So what is the ideal treatment for type 1 diabetes? It should induce a weight loss in overweight individuals. It must improve HbA1c without increasing the risk of hypoglycemia. It must reduce the risk of cardiovascular diseases, and it must address the abnormal alpha cell function. Now, alpha cell is important for glucagon production. Now, type 1 diabetes results from beta cell destruction. Insulin therapy remains the cornerstone of management. However, it has its own drawback. That's the reason researchers were made to search for adjuvant treatment for type 1 DM. So what are the drugs that have been used for research as an adjunct, as a research for adjunct to type insulin in type 1 diabetes patients? I got a couple of studies in which research has been done on drugs like metformin, alpha glucosidase inhibitors like voglibose, acarbose, thiazolidines, GLP-1 RA inhibitors, DPP-4 inhibitors, and SGLT2 inhibitors, and pramlintide. Pramlintide is a newer drug about which I'm going to tell you a little in details. So pramlintide is an amylin derivative. The mechanism of action of amylin or pramlintide is like this. You can see this chart here in this slide. Pramlintide induces satiety. It delays gastric emptying and suppresses glucagon secretion, mainly through the action on the CNS. These effects result in weight loss, inhibition of hepatic glucose production, and slowed gastrointestinal absorption of glucose, eventually leading to decreased postprandial glucose concentrations. Pramlintide is an injectable amylin analog that was developed and approved by the US FDA in 2005 for use in individuals with insulin-treated type 1 diabetes or type 2 diabetes as an adjunct to mealtime insulin. Pramlintide has the same physiological effects in human beings as amylin, including food intake. Its plasma half-life.
മരുന്ന് അയച്ചു തരാം എന്നിട്ട് ഭക്ഷണത്തിന് ശേഷം കഴിച്ചാൽ മതി വായിച്ചു
Its plasma half-life is 26 to 50 minutes and maximum concentration occurs about 15 to 30 minutes after injection. It's available in the market, not in the Indian market, of course, and in very few countries it is used across the world, mostly as a research drug only as of now, and in the form of injections Simlin. So what dosage and contraindications for pramlintide would be recommended? Recommendations suggest beginning pramlintide therapy as a 15 microgram dose before main meals, concurrently reducing the dose of postprandial insulin by 50%. The dose of pramlintide should be escalated by 15 micrograms at intervals of 3 to 7 days to a maximum dose of 60 micrograms. Pramlintide should not be used in patients with poor compliance, recurrent hypoglycemia, gastroparesis, CKD, or those who are unwilling to monitor blood glucose concentrations frequently. There's a study in which a randomized study and an open label extension evaluating the long-term efficacy of pramlintide as an adjunct to insulin therapy in type 1 diabetes. It was done by Whitehouse et al. So here we can see that the reduction in HbA1c at weeks 13 and 52 was significantly greater with pramlintide compared to placebo. And at week 52, the mean total daily insulin for the groups increased by 2.3% in the pramlintide group and by 10% in the placebo group. So there was a significant reduction in the insulin requirement as well in the pramlintide group. So this was one drug, which is this pramlintide is the only drug that is actually presently FDA approved. But the cost factor and the availability across the world is really a question as the present problem. I have almost discussed with many of my endocrinologist friends and with my diabetologist friends across, but many of them are not still aware about, many of them are still not using it in their day-to-day practice, and not at all in India as of now. Hopefully it should be coming soon, waiting for that. So there are incretin-based therapies in which GLP-1 receptor agonists and DPP-4 inhibitors are also used. So how do GLP-1 receptor agonists and DPP-4 inhibitors, they act by stimulation of insulin secretion, inhibition of glucagon secretion. They act on delaying gastric emptying and reducing food intake. But if we compare in this chart as well, but the patients who are on GLP-1 receptor agonist treatment, they have a better reduction in the HbA1cs and glycemic control compared to DPP-4 inhibitors. Coming to GLP-1 receptor agonist a little in detail, endogenous GLP-1 is secreted from L cells distributed throughout the small and large intestines in response to food ingestion, and it has a pleiotropic effect such as enhancement of glucose-induced insulin secretion, inhibition of glucagon secretion, delayed gastric emptying, and induced satiety resulting in weight loss. GLP-1 receptor agonists induce weight loss and reduce insulin requirements with either improved or unaltered glycemic control. So the GLP-1 receptor agonist, which has been studied as of now in few of the papers, is liraglutide. So injection liraglutide was studied in different studies with the in the dose of 1.2 mg once per day and 1.8 mg once per day. So I'll tell about 4 studies. One study was done by Franson et al., where 1.2 mg of liraglutide once per day was given. Here, the baseline HbA1c of 8.2 reduced to 8.2% by the end of the treatment. And there was a reduction in the bolus insulin by 11%, with a reduction in the body weight by 4.1%, that is by 3 kgs. Another study by Girdhar et al. In this 1.8 milligram of liraglutide once per day was given. Here the baseline HbA1c reduced from 8.7% to 8.2%. Then the basal insulin change was by 12% and bolus insulin change by 2%. Here also there was weight reduction by 5.8 kg. If we see the chart, when the liraglutide dose is a little higher, there is more weight reduction, and as well as bolus insulin change, also bolus insulin level also is changed. Another study, adjunct 1, here 1.2 milligram of liraglutide once per day was used. By 8 point, the baseline HbA1c was reduced from 8.2% to 7.7%, and the reduction in body weight was around 3 to 4 kgs. Harrison et al., this was one of the longest studies done for 10 weeks. Here also 1.8 mg liraglutide was given once per day. The baseline HbA1c changed from 7.4% to 7%, and again a weight loss of 3 kgs was observed. So we can see that liraglutide is a promising drug again here. So one point needs to be seen, that we are not stopping the insulin completely over here, but these drugs are helping us to reduce the amount of insulin that is needed for the patients. So coming to DPP-4 inhibitors, these lower blood glucose by extending the half-life of endogenous GLP-1 and glucose-dependent insulinotropic polypeptide. After secretion from L cells, GLP-1 is degraded by DPP-4 within 2 to 3 minutes. Thus, DPP-4 inhibition increases the concentration of endogenously secreted GLP-1 by 2 to 3 times. In diabetes type 1, patients, when there is inappropriately raised glucagon secretion also, addition of DPP-4 inhibitors to insulin could improve glycemic control and reduce insulin demand in such patients, and enhance insulin secretion in patients with residual endogenous insulin secretion. So there is one study. We have 2 studies. One is done on vildagliptin, and other is done on sitagliptin. In this study, we can see the effects of vildagliptin on glucagon's concentration during meals in patients with type 1 diabetes, study done by Foley et al. Here we can see in the first graph, mean of intact GLP-1 here, and intact GLP-2 GIP in the panel B. Here during standard breakfast meal, after 4 weeks of dosage with placebo and vildagliptin, there is significant difference in the in the increase of GLP-1 and GIP. Here, the dosage of vildagliptin used was 100 milligrams twice a day. The same thing is there in this slide also. Here, mean of glucagon is seen in panel C, mean of glucose is in panel D, and injection list pro insulin in sorry, during a standard breakfast after 4 weeks of dosage of placebo. To tell you the conclusion of this. So 4 weeks of vildagliptin, 100 mg BD treatment. This treatment markedly decreased the post-meal glucagon excursion in these insulinopenic patients with type 1 DM. Glucagonostatic effect of vildagliptin is not mediated indirectly by a local endocrine effect on endogenous insulin. Furthermore, the magnitude of the effect of vildagliptin to suppress post-meal glucagon secretions in patients with type 1 DM is similar to that observed in type 2 DM. Like in type 2 DM, how it helps? Similarly, it is helping here in the post-meal glucagon secretion. So postprandial hyperglycemia also can be taken care of with these drugs. So this diagram shows is this article shows us about effect of sitagliptin on glucose control in adult patients with type 1 DM. This was a pilot double-blind randomized crossover trial study done by Ellis et al. So here the mean glucose and HbA1c was significantly lower in the sitagliptin treatment group compared with the placebo group. This dark one is the dark black, I mean like the black one is placebo, and the gray color is shown by sitagliptin. Here also the time spent in euglycemia was significantly higher, and despite a decrease in the insulin dose during the sitagliptin exposure when controlled for treatment and period effects. So the study outcome for sitagliptin was it significantly improved overall glucose control, including postprandial and 24 hours glucose control in adult patients with type 1 diabetes, while significantly reducing prandial insulin requirements. Another promising drug was metformin. So metformin mainly decreases the hepatic glucose production, and also induces minor weight loss in individuals with type 2 diabetes. So it doesn't help much in the HbA1c levels, and neither in the insulin requirements it doesn't help much. But yes, it reduces the weight, and that ways it can indirectly help in reducing the insulin requirement of the patient. Sorry. So findings from 5 randomized clinical trials provided appropriate data for the meta-analysis, suggesting that metformin significantly reduced insulin requirements by 6.6 units per day and was associated with a small reduction in body weight, but without any significant effect on glycemic control. That is, HbA1c was only 0.11% reduction. Effect of adjunct metformin treatment in patients with type 1 diabetes and persistently inadequate glycemic control, a randomized study. This study also, the findings of the study showed a reduction from baseline 5.7 units per day in total insulin dose and a weight loss of 1.7 kgs compared to placebo, but without any effect of HbA1c. So metformin has not helped much according to these studies. Coming to the SGLT2 inhibitors. So the mechanism of action of SGLT2 inhibitors are SGLT1 and SGLT2 selectively decrease their glucose transport activity in the gut and kidney. So inhibition of this process increases renal glucose excretion and reduces gut glucose absorption, leading to reduced plasma glucose concentration and a reduction in the body weight. Studies I could find was only on canagliflozin. This is the largest randomized trial with SGLT2 inhibitors in type 2 diabetes. It was an 18-week study wherein, wherein 100 mg and 300 mg of canagliflozin was used. Total of 351 individuals were studied, in which 300 mg of canagliflozin was given to 117 patients, and 100 mg was given to the remaining 50% patients. So what happens in the 300 mg group? There was a baseline, the baseline HbA1c reduced from 8 to 7.8. Baseline insulin change was 7.5%. By 5 kgs. So if we compare it to 100 mg canagliflozin, hello. Hello, am I audible?
Audible.
Sorry, thank you. So if in the second 100 mg canagliflozin group, we could see that the baseline HbA1c was dropped from 7.9% to 7.6%. Baseline insulin change was 3.7% and 7.5% reduction in the bolus insulin change. Weight loss also was 3.1%. So optimum dose of 300 mg was better compared to 100 mg per day of canagliflozin. So to summarize and conclude, several barriers interfere with achieving target HbA1c in patients with type 1 diabetes, despite the proven benefits of tight glycemic control with insulin in individuals with type 1 diabetes in reducing diabetic complications. The risk and fear of hypoglycemia and potential for weight gain are limitations of treatment, and only a few patients achieve the treatment target. So the treatment strategies for type 1 DM would be reduction of raised postprandial glucagon secretion, reduction of risk of hypoglycemia, avoiding weight gain, improving insulin resistance. And there is a clear scope for the use of non-insulin based therapies to help in the management of type 1 diabetes. Right now, presently, only pramlintide is a drug that is FDA approved, and but it is not yet available and not used very widely, not available in India too as of now. So hopefully we can come up with some magic drug which would at least help the type 1 diabetics, especially who have to be on lifelong insulin. So thank you. Thank you, Dr. Vineet, sir, for giving me this opportunity.
Dr. Sheetal, the presentation was excellent, and if you can tell about the new drugs again as a take-home message, it will be great, because older drugs we all know. You were mentioning, I think, a few new drugs. Even you were telling your colleagues who are not using it. So if you can tell as a take-home message, it will be great.
Okay. I would talk about pramlintide, sir. That is the one which I searched a lot. I spoke to many of them, and look, I couldn't find anybody who would talk about it. So pramlintide is a drug which would induce satiety. It inhibits glucagon secretion and it delays gastric emptying. I will just tell about how it is an injectable amylin analog, which the dose, the plasma half-life is 26 to 50 minutes. And we usually give it as a 15 microgram dose before main meals. It is a single dose usually, and we need to escalate it from 15 mg every 3 to 7 days. We can increase it. Maximum dosage is 60 micrograms. It is avoided. It is to be avoided in CKD patients. It is to be avoided in patients who have poor compliance and who are prone to more hypoglycemia.
Thank you very much. It was great presentation. And I think you are becoming more a diabetologist than a cardiologist, it seems. Such a fluency in presentation. Thank you very much.
Hello, can I ask you a question here?
Yes, sir, please.
Madam, whatever study you have shown, that is from 2008 or whatever, 11, very old studies, number one. And number two, the scope of this pramlintide is in India, as per you said already, it has not been used by the people. And thirdly, liraglutide is a drug which is, I think it is not available orally. Your topic was OHA.
Yes.
And fourth one is, I think currently there is no drug which can be used in type 1, which can either replace or that one.
Sir, actually my topic was only OH in type 1 diabetics, but we cannot use the OH in type 1 diabetics because of the extensive beta cell destruction that is there in, or beta cell that are like almost none in type 1 diabetics. The thing was, initially only I said that we couldn't find a single drug that can replace insulin. It was like an adjunct wherein we can reduce the insulin that is needed for the patient. Okay.
Seems not to be even adjunct. I feel so ki maybe in some restricted number of the patient where probably you are not able to do much with the insulin, or there is some problem with the insulin, probably there may be some trial that can be done with them. Otherwise, OHA in type 1 not seem to be very promising. Thank
no,
you.
not seem very promising. The studies that we have found, Anna, they are also done on a very couple. That's why, sir, I had to dig out a lots of articles to find out where I mean, like, I actually appreciate myself for this, that I could find out these many articles, because every drug, it was really like, and not very fresh studies we have found even on the DPP-4 inhibitors, on the SGLT2 inhibitors. And like I said, pramlintide was only one new thing that I could find. But I think almost across the globe, I have friends whom I've asked, are you all using it? But none of them said that as of now it's
And this drug is associated with the hypoglycemia, as you said,
Yes.
with the GI symptoms.
Yes,
All
sir.
those, nobody
Yes.
will be ready to use this one.
Yeah, no, the side effects are definite, and the problem is that the cost. It's the cost. It's a very expensive drug. So that is there. So as of now, I have only mentioned drugs that can be used, that can be used, but none of them is like
I
FDA.
hope that drug like semaglutide or the other drugs, new drugs, maybe have some wonder effect, but so far there is nothing, no news regarding these.
Yes,
the
yes.
type
You're
one.
right, sir.
Thank
You're
you,
right,
madam.
sir. Thank you, sir.
First of all, I must thank Dr. Sheetal for this out-of-box presentation. Dr. Arjun, you very rightly said that OHA has probably no role in type 1 diabetes. But the topic which was given to Dr. Sheetal, seeing that she will be able to move through this particular difficult topic, because in clinical practice, we as clinicians invariably see patients who insist on OHA rather than insulin. We all know as clinicians that insulin is the treatment in type 1 diabetes. Now, and I must congratulate Dr. Sheetal for the hard work which she has put in to make this presentation. Dr. Sheetal, can you just stop sharing the slide? I would like to share something and show something. There has been a trial called EASE-1 trial on empagliflozin, which has been used. Momita, can you help, please? Yeah.
Yes.
Which has been used as an adjunct therapy, as Dr. Sheetal was rightly saying. We can see here in conclusion, in patients with type 1 diabetes, EMPA for 28 days was used as an adjunct to insulin, increased UGE, which helped to improve A1C and reduce the weight with lower insulin doses compared with placebo without increasing hypoglycemia. And this trial comes from Boehringer. So there is some credibility to this, reiterating that when we talk about this, we are once again understanding very clearly that there is no alternate to OHA. No alternate to insulin. These are just an adjunct to the standard medical therapy. This will probably help in reducing the insulin resistance or maybe reducing the doses of insulin that might be used in clinical practice. Coming to
some restricted number of the patient where probably you need some adjunct. Otherwise, if you see this study, when it is of 2015,